We are live now, Doctor. You can start the session.
Sure. So, good evening, one and all, and welcome to part two of our Path to Precision Refractive Surgery series. So, as a part of the refractive focus group of the YOSI Society, it gives me great pleasure to welcome everyone to the second part of our series. In this part, we will be discussing about the applications of the Excimer laser for corneal refractive surgery. So, I'll just be sharing my screen now for the introduction. So the Paths to Precision series is an initiative from the YOSI Refractive Focus Group. As one of the focus groups, which is initiated by the Governing Council of the YOSI to further educate the YOSI members about specific subspecialties of ophthalmology. So this is going to be a 5-part module. This will aim to cover all the nuances of refractive surgery. We'll be starting right from the basics to the more advanced topics. It's aimed at young practitioners who have just embarked on their journey and want to start refractive surgery at their practice. This is going to be a 5-part module. So the format is that the speakers are all going to be young YOSI members giving their inputs on their experience of refractive surgery. An input and keynote address will be given by an established doyen in the field. So on episode 1, we covered the basics and we had a very interesting episode. So this was about how exactly to set up your practice to have success in refractive surgery. We had Dr. Sri Ganesh, who came as a guest speaker and keynote address. We had addressed on everything, right, about how to set up your practice, what equipment to buy, refraction for refractive surgery, how to evaluate a patient, and how to further educate yourself to get better results with refractive surgery. So this is the second part where we'll be focusing on corneal refractive surgery, specifically with Excimer laser. The third part will be on lenticular extraction, and the fourth part we will go into phakic IOLs, and the fifth part will be on refractive cataract surgery. So the history of Excimer laser is actually very interesting. So it all began in the early 1980s. If you go look into it, it was really initiated by Dr. Stephen Trokel, where he was inspired by the use of Nd:YAG lasers in cataract surgery and began to explore the use for corneal reshaping. And then John Taboda, who was actually an engineer in IBM, noticed that you can use the Excimer laser for micro etching of computer chips and noticed that there was precise tissue ablation without collateral damage. So this really caught Dr. Trokel's attention. So this is what led to the whole idea of using the Excimer laser for corneal reshaping for photoablation. It was first used on human hair, and that's when they proceeded to use it on calf corneas. In the mid-1980s, it started to take a real form, where Charles Manolin developed the formula for calculation of the amount of tissue needed to remove specific amount of tissue for refractive correction. This is when the term PRK was coined. And the first Excimer laser was done by Dr. Margaret MacDonald, who used it on a patient who had an orbital tumor who was about to undergo exenteration. It was done on a patient who was actually uncorrected 2020, and they used it for a myopic correction of 4.5. Then that was the first patient who actually got PRK. FDA trials began in 1989, and if you look into it, it's very interesting. A lot of these patients were off by several diopters, whether they were off by 3, 4 diopters. This was really unimaginable. In our times, being off by even half a diopter gives rise to unhappy patients. 1990s, LASIK emerged, and PRK received its US FDA approval. And in the mid 1990s to the late 2000s, customization and refinement of the Excimer laser really began. We began to have video keratography and aberrometry to become essential diagnostic tools to assist and enhance the safety of Excimer laser vision correction. And now we have the femtosecond lasers, which are being used to create flaps, which have given rise to less incidence of flap-related complications in LASIK. So in this episode, we're going to cover right from the A to Z of the Excimer laser applications. We will start with the PRK, which will be addressed by Dr. Sandeep Chowdhury. We'll move on to LASIK by Dr. Lipi Mittal. And then we have a guest speaker, Dr. Pooja Kamar, who will be talking about personalization in refractive correction with Eximers. Presbyopic LASIK will be addressed by Dr. Sushmita Sri Ganesh, and optimizing outcomes and managing complications by Dr. Arnav Saria. And now gives me great pleasure to welcome our expert panel and keynote speaker, Dr. Pooja Kamar. She's a cataract, dry eye, and refractive surgery consultant at Narayana Nethralaya Eye Institute. She's done a PhD in refractive surgery from Maastricht University in Netherlands. Former fellow at Narayana Nethralaya, she's now become a prominent consultant and researcher in Bangalore. Extensive experience in cataract, refractive surgery, and dry eye, and expertise in all laser-based platforms. She has numerous publications, invited faculty in many national and international conferences, recipient of the prestigious Troutman Award, and recognized as one of the top 10 eye doctors globally. Was also awarded the Rising Star Award by the Ophthalmology magazine. I frequently run into Madam in the halls of the ACRS conference where I ask her one question. I don't ask her if she has won a best paper. I ask her how many best papers she has won. And it's usually in the 3 or 4 numbers. So this is my introduction. And with that, I would like to invite the first speaker to give the talk. And before we begin, can we have Dr. Pooja Kamar give a few words before the session starts?
Thank you, Aditya. First of all, a very effective planning of the entire series. I really loved what you guys have planned, the various episodes and what you're doing. It will be really helpful for all the young ophthalmologists. And thank you for the kind introduction. But I think I'm still young and one of you, so I still have a lot to achieve. So don't call me ma'am. Dr. Pooja is fine. And it would be wonderful to see all of the young ophthalmologists turn up into a very refined refractive surgeon doing one of the best refractive surgery for all the patients, because though a lot of people say we just do a cosmetic surgery and we are doing nothing great, I think all the refractive surgeons are doing a, a very I would say a job which is has to be taken with utmost precision, because our patients have been seeing 6/6 and they want to see 6/6 next day, so you can't go wrong here. So I think we also have equal responsibilities on our shoulders as other surgeons. So good initiative, and looking forward to the episode. Thank you for the invitation once again.
I remember, ma'am, I visited your CROC program when I was a final year PG. That's when I really learned about corneal topography and the basics of refractive surgery was learned at Narayana Nethralaya, Bangalore. And I remember, so that's when Dr. Rohit Shetty also mentioned it's not just cosmesis, that you are really correcting the vision of a patient and you're improving the quality of life. So that's when it dawned upon me that we must give due respect to refractive correction and not just consider as cosmesis, but as something that enhances a patient's quality of life, just like how we do for cataract surgery. You can even make the argument that it's even more important than doing cataract surgery because we discussed this in the first episode. We are treating people who are in their most productive years, in their 20s and 30s. That's going to have a big impact on the most productive years from the 20s, 30s to 40s.
Yep. So I think we have equal responsibility for a patient's life as others do.
Exactly.
Yes. And like you started with Dr. Margaret McDonald doing the first PRK and what used to happen. And we are now advanced where you name the option and we have it. And everybody have their favorites. Some of us have LASIK, in that you have Contura Wavelight Plus. Some of us have Smile. Now you have Silk, Clear, Smart Sight, Phakic IOLs, multiple things. But sometimes every company claims that this is the best procedure and we are the best. I think what works in your hand is more important, so that is what a refractive surgeon needs to learn.
Correct.
And advancing with age, your PR can also give you 20/10 vision, and a lenticule and phakic also can give you 20/10, but choosing the right procedure is the way forward.
Absolutely, ma'am. Absolutely. Okay, so with that, let's move on to the first talk. So, may I invite Dr. Sandeep Chowdhury? Let me just make the introduction quickly. So Dr. Sandeep Chowdhury is going to talk to us about PRK, its techniques and indications, and how to perform the procedure. Dr. Sandeep Chowdhury has done his MS from PGI Chandigarh, and he's currently a consultant at ASG Eye Hospital, where he specializes in cornea refractive and glaucoma services. He has 17 publications which are indexed to his name. He's also been awarded the best paper presentation at the United Kingdom Pediatric Glaucoma Society and the Indian Pediatric Glaucoma Society. It has also won Best Surgical Video Awards. So thank you, Dr. Sandeep, for joining us, and we are looking forward to hearing your talk.
Thank you, Dr. Aditya, for the opportunity and the wonderful introduction. So I'll start with sharing my presentation here. Okay, is it visible now? Hello?
Yeah, no, not, yeah, now it's visible,
Okay.
yes.
Okay, thank you. Good evening, everyone. I will be discussing photorefractive keratectomy, some basics like patient selection, procedure, and the technique. And with the plethora of refractive surgeries which are available, and just as the ma'am said, which refractive surgery is best is a constant debate, and I think what works best in your hands, as the ma'am said, and also what is how the how what suits best to the patient. So we need to take into account the history and the needs of patient, and what the clinical examination entails, and the investigations tell us, and then only we can decide what's best for the patient. So all starts with the history, age of the patient, and the use of glasses. We need to establish that patient is has a stable refractive error for past at least a year, and we also need to see when was the last time patient used contact lenses, because we tend to we try to keep a 2 to 4 weeks gap between depending on the contact lenses before we do the preoperative evaluation. And one of the most important thing, I think, is the patient's expectation. We need to keep the expectations of patient very realistic. So with that, so the ocular history specifically, we need to know if the patient is using any eye drops, even if it is lubricating eye drop. Then also we need to know if the patient is having dry eyes or something like that. And also the uses of contact lenses, if the patient has any history of previous surgery or any infection. Sometimes some trivial viral conjunctivitis infection also leaves some footprints like subepithelial infiltrates or so. So we need to know it all, and also the other ocular comorbidities like glaucoma and everything. Uh, Apart from that, the systemic history, if the patient is diabetic or patient is having any autoimmune disorder, collagen vascular disorder, pregnancy, lactation. The thing with systemic disorders like diabetes and all is that they tend to create fluctuating refractive error if they are left untreated or uncontrolled. So we need to know if the systemic problems are in control. Also the history of any drugs intake like isotretinoin and or amiodarone. All these is important because they also tend to create variable side effects like isotretinoin is known to cause dry eyes and blepharitis and things like that. So that's also important. Apart from that, the profession of patient, if patient is into contact sports, or if the patient is into say some army or something like that, the profession which exposes them to higher chances of ocular trauma, which can then we tend to avoid the flap based procedures for these patients. Also anxious personality, especially the patients who are claustrophobic or like that. So we must discuss this with the patient, because such patients may have difficulty during the surgical procedure, and then in the middle of surgery this can be a problem to manage. uh, with that, to proceed with the clinical examination, of course, we need to know the uncorrected and corrected distant visual acuity, and also the near vision, dry refraction. Cycloplegic refraction is very important, because in both in the case of myopia and hyperopia, we need to exclude pseudomyopia, and we also need to know if the patient has any latent component in patient's hyperopia, so that we don't end up correcting having an under correction, things like that. Also post-metatic test. Near point of convergence is also important, because myops, they tend to have a lower convergence, weakness of convergence. So if this is the case, then we have to explain to the patient that they need to do the convergence exercises, even sometimes even before the surgery also. And apart from that, Examination should always start with a diffuse examination, a diffuse light examination or torchlight examination. So it should start from the eyelids if the patient is having any, what's the position of eyelids if the patient is having any component of ptosis or a frank blepharitis, or the position of the eyeball. We need to rule out the phoreas beforehand, ocular motility, and the palpebral aperture. Sometimes, in cases of deep set eyes, if the patient is having very deep set eye, then it becomes a problem, especially while planning some femtosecond laser procedures, because the docking becomes very difficult in very deep set eyes or narrow palpebral aperture cases. So everything is important. You need to examine the patient thoroughly. So even on the slit lamp, starting from the eyelids also, because sometimes even if the patient is asymptomatic, there are things which you discover on the examination, like concretions can be there underneath the surface. There can be papillae, or like this patient here, the patient was a 35-year-old male, and he did not have any symptom of blurring of vision per se because of this, and but on examination, patient had granular corneal dystrophy. And like in this patient, she was a young female, and she had a history of viral conjunctivitis, and she was having these subepithelial infiltrates, which she never noticed. So, and these things become very important while doing a cornea-based refractive procedure specifically. So everything is important, and we need to examine the patient thoroughly along with the dry eye workup. So I will not get too much into this thing because the scope of our discussion is specific to PRK today. So proceeding with that, we need to do investigations for the proper surgical planning. First and the most important thing nowadays is corneal tomography. So pentacam, which is an elevation-based corneal tomography, we need to know the red flags, which we'll discuss in the coming slides also. So these are the red flags which we need to know so on the quad map display. We need to know on the sagittal map and pachymetric map if the corneal thickness is lower. All these points I will be discussing in the coming slides. And apart from that, pupillometry is important, specifically the mesopic and scotopic pupil size, because we want to keep our optical zone at least higher than the scotopic or mesopic pupil to decrease the incidence of nighttime glares and halos. Also nowadays, the corneal biomechanics is also gaining very much attention, because we believe that ultrastructural changes, they tend to precede the corneal shape changes, so Corby ST and all. And apart from that, the wavefront analysis is important to know the higher order aberrations, and based on the amount of higher order aberration the patient has, we need to plan if the patient needs an optimized, customized, or wavefront guided or topography based procedure, which we will discuss in today's session only, I think. So this is important. Now coming to specifically to the PRK, the FDA approved range for PRK, there's a wide range ranging from +6 in hyperopia to -12 in myopia, and also estimated up to 6 diopters. But practically, I believe we tend to prefer PRK for mild to moderate myopia only. On the higher side of myopia, beyond, I think, 6 or 7 diopters myopia, personally, I feel a bit uncomfortable doing a PRK for a higher range of high refractive error. And the depth of ablation, we need to know, we can calculate beforehand with the Mullins equation, which depends on the optical zone and the degree of myopia. So the optical zone should be at least higher than the mesopic and scotopic pupil, as we discussed. So if we put in the value of optical zone of 6 and 6.5 mm into the Mullins equation, then roughly what we get is about 14 microns of ablation for 6.5 mm optical zone, and about 12 microns of ablation per diopter for 6 mm optical zones. So this is how you can know what ablation depth you are going to get with any particular correction. With this ablation depth, this can give us a residual stromal pad thickness, which we are expecting post-surgery. So theoretically, in the literature, what is written is that the residual stromal pad should be at least 250 microns, but practically, I believe most surgeons tend to keep it at around 280 to 300 microns at least. There are a variety of ectasia risk scores which have been given in the literature, Renderman ectasia score being I think the oldest one of the oldest ones. So this also decides this also gives us a rough idea of how much of the risk of ectasia is there with any particular patient based on 5 parameters, which include topography, the residual stromal pad thickness, age, corneal thickness, and spherical ablation, spherical equivalent of the mean refractive spherical equivalent. So Naturally, if the patient is having normal topography, residual bed thickness more than beyond 300 microns, higher age, better corneal thickness, lower refractive error, then the risk of ectasia is towards lower. So if the 0 to 2 score is considered low risk. One thing which we should always do before proceeding with the surgery every day is fluence check or calibration of the machine, which is very important. As we all know, the Excimer laser is basically an excited dimer of argon and fluoride, which is produced when we pass high voltage electricity discharge from um, um, the gases, argon fluoride and the helium, they come in a single or double cylinder housing of, it depends on the machine, like in the one which we use, EX500, it has a single cylinder housing of argon fluoride and helium. So a high voltage electricity discharge through this will create a dimer, excited dimer of argon and fluoride, which tends to create non-thermal ability photo decomposition. The fluence check, although it varies with different machines, but the basic philosophy remains the same. This, which is to check the myopic sphere calibration, cylinder calibration, and hyperopic spherical calibration before proceeding with the surgery. That any particular amount of energy which the machine is spending, and then how much the correction, which if we are getting the intended correction or not. This also varies with the temperature and the humidity in the operating room. So humidity also plays an important role. If the humidity of operating room is lower, then the residual stromal bed tends to get dry, and which eventually results in overcorrection. And if it is a higher, if the residual stromal bed is uh, wet because excessively wet because of high humidity, then we can expect an undercorrection. So this is important before proceeding with the surgery. So the first step in the PRK would be epithelium removal. Epithelium removal we can do with alcohol. We can do it with the machine also. So for doing this is the alcohol-based epithelium removal method. So we take a well and then then put in a few drops of 20% ethyl alcohol into the well, and then keep it for around 30 seconds, 20 to 30 seconds, and then soak it with a dry emulsive sponge. So it is important to soak it beforehand and from the well. And then as soon as we remove the well, we need to wash it thoroughly so that any residual amounts of alcohol are washed off from the ocular surface, and so that they don't cause any localized toxicity. And then the epithelium, it comes off very easily. So you can just remove it just like that, and it will come off very easily. Just and then the residual some amount you can also remove with the hockey stick also. And you don't need to go too much into the periphery, because it will further delay the epithelium healing. What we need is around 8.5 to 9 mm of the central area of epithelium denudation. And then the another method to remove the epithelium or to do the PRK would be a single step PRK, also known as trans PRK. It comes with a different name with a different machine. The one which we use, EX500, it has a streamlined feature with it. In this, the machine itself removes the epithelium and then proceeds with the ablation in a single step only, so thus reducing the surgical timing. So the epithelium thickness also varies from the center to the periphery. In the center, it's around 50 to 55 microns, and then in the periphery, it goes until 60 to 65 microns. So the machine in itself will create this differential amount of this ablation of the epithelium first, and then proceed with the ablation for the refractive error. So this is how it is done in a single step only. So this is another video of the streamlight or trans PRK, only the magnified view, so that you can see how the machine proceeds with it. So this way the surgical timing is reduced. Now comes the mitomycin C. So mitomycin C is an alkylating antimetabolite. It is very important to decrease the postoperative haze, although many surgeons prefer not to use it, and there are a variety of exposure time which are mentioned in the literature. So the concentration which we use generally varies from 0.002 to 0.2%, and the timing varies from 12 to 120 seconds. The general principle remains that around 10 seconds per diopter you can time is the timing which we can use for the mitomycin exposure. And after the application of mitomycin C, it is very important that you wash off the any residual mitomycin which is there. The same way we remove after the exposure of the alcohol, because we want to just wash it off, wash off the ocular surface so that no residual amount of mitomycin is left and no local toxicity is there. So after washing off the ocular surface, what is left is just implant. We just put in a BCL on the bandage contact lens, and we are done. So the post-operative care is a bandage contact lens and topical antibiotics till the time reepithelialization is completed, and also topical steroids and lubricants to just for a symptomatic improvement. So what are the situations where we prefer PRK over LASIK? So PRK is a procedure of choice whenever there is a borderline thin cornea where we are expecting a residual bed of less than 300 microns, and there is because of the profession or the contact sports, or there is any corneal surface disease, or the cornea is excessively flat or steep, which can result in a free flap or a buttonholing of the cornea during the flap formation if we proceed with the LASIK. Patients with deep set eyes where where the formation of flap is difficult, or narrow palpebral aperture. In sometimes also in the enhancements or retreatments also we prefer PRK over LASIK. Rather than relifting the flap, we can just go ahead with the PRK. So these are just a couple of cases which I will be discussing briefly. So this is the case one. The patient was 22-year-old female and presented with 3 by 60 vision uncorrected and 6 by 9 best corrected visual acuity. And the refractive error was in the range of about minus 0.5 diopter of myopia with the minus 1 diopter of cylinder. So on the pentacam evaluation, the patient has the pentacam was seemed fine apart from the thinnest local, which was 465 microns. So patient had a thin cornea. The Kmax was 47.3 diopter, so has a steep cornea. So these are the red flags which we were discussing. So on the quad map, we can see the red flags which we need to see. If the Kmax is more than 48, the patient has a skewed radial axis more than 21 degrees. If the inferior superior asymmetry in the 5 mm zone is more than 1.4 diopters, or the Kmax and K2 difference is more than 1 diopter. Also on the corneal thickness map, if the patient has a corneal thickness of less than 470, if the apex and thinness local difference is more than 10 microns, the Y coordinate, this is very important, the Y coordinate of thinness local is if it is more than 0.5, minus 0.5, and the thinness local difference of thinness local more than 30 between both the eyes, and the superior inferior asymmetry of more than 30 microns. So these are a few red flags which you need to see on the quad map display. Apart from that, elevation also. So if it is the data is from 8 mm diameter in diameter, then we need to see if the front elevation should not be more than 8, and the back elevation should not be more than 16 microns. And if the data is from the 9 mm diameter floats, then it should not be more than 12 microns in front elevation and about 17 microns in the back elevation. So this is important. Apart from that, the Berlin ambrosia enhanced ectasia display also of the same patient, the right eye, the patient, even if the D value you see, the D value because of the pachymetric progression and the thickness was in the suspect range. Apart from the ambrosia relational thickness, and the front and the back elevation were fine. In the left eye also, the patient had a similar picture: thin cornea, high Kmax, and so this is the pachymetry. So what were the options? So if we calculate, the ablation depth would come around 84 or 80 microns, 80 to 85 microns in both eyes, and the central corneal thickness patient had was 450, around 460 microns. So the residual stromal bed, if we go ahead with the LASIK, even with the 90 micron flap, would come around 285 and 290 microns. So which goes below 300 microns, and the percentage tissue altered would be around 38 percentage. So this, although some surgeons may consider it marginally safe for LASIK, but still I would think that the stromal pad which we get with the PRK, and even in the marginally thin corneas, PRK would be a better option to do. So we proceeded with the trans PRK streamlined procedure in this patient, and the patient is fortunately doing fine now. So this is another case, a 19-year-old male who presented to us with post LASIK. So this was at the time around 6 weeks post LASIK. The right eye was doing fine. In the left eye, the patient has a residual astigmatism of about 0.75 diopter cylinder. So usually, I wouldn't bother much about this much of refractive error. But for professional reasons, patient needed 6 by 6 unaided visual acuity. So we had to plan something for the patient. On the cirrus, the patient, this is after a post LASIK, the cirrus map. The patient, the topography was fine only after even the LASIK. So in this patient, we could have gone ahead with the flap relifting and then do a retreatment and reposition the flap reflow. But what we thought was that we can go ahead with the PRK because it's just a 0.75 cylinder correction, and we went ahead with the left eye green light in this patient, and the post-op outcomes were satisfactory. So this is how you can proceed with the PRK in certain cases, in the retreatment also, in the primary treatment also. Thank you.
Thank you so much, Dr. Sandeep. I think that was a very extensive overview of PRK. So, although we primarily do lenticular extraction in our clinic, we still do PRK every couple of times a month because there are some indications for it. I always believe that even though that the lenticular extraction is gaining traction and is probably the present and the future of myopia correction and refractive surgery, PRK is not going to go away. There might be lesser adoption of LASIK in the upcoming years, but for sure there is indications such as this, the borderline corneas, low myopia, where PRK will be necessary, especially with enhancements. And also, thank you for mentioning the impact of fluence checks before every session, because that is very important. Temperature, humidity, everything can impact the fluence and the energy output. So I do fluence checks before every patient actually. So that really helps. So you'll have lesser incidences of overcorrection or undercorrection. And now I would like to invite Dr. Pooja Kama to give her inputs on Dr. Sandeep's talk on PRK.
I think, Aditya, you did mention the points that with advances with phakic IOLs and lenticulates like smile extras, you do have an option to treat the corneas where you're not very confident on doing a LASIK procedure. However, if there is one procedure which has stood the test of its time is PRK. I think whenever you are in a subtle doubt whether this is going to work or not, blindly go ahead with PRK because there is enough reports suggesting the minimal incidence of an ectasia with PRK compared to that of smile extras. Vicky yes, is an option, but it has its own apprehensions when it comes to patients. So trans PRK is the way, sorry, PRK is always going to be staying there. And I think I'll show a few slides on where we have moved when it comes to trans PRK and where we are going to go forward. So I don't, whenever you are like in your journey of refractive surgery, it's not just one procedure you have to know all the procedures.
Correct. Yeah, so I think you brought up an important point, ma'am. So I'm going to ask you a question now. Trans PRK or PRK? So one of my doubts about trans PRK always was, I feel unless you have a modality to check the epithelium before the trans PRK, it's difficult to do it and get an accurate outcome, because in many of our patients, you see that they have patchy epithelium. It'll be 50 microns in one area, and then there's another band of 60 microns of epithelium. And then when you input your epithelial thickness is 50, you're going to get an uneven ablation profile. So how do we address that, ma'am?
You're absolutely right here. Trans PRK do have its own challenges. If you don't have an epithelial map in your practice, I don't think you should go ahead with it because sometimes you have an epithelium of 70 in a very healthy looking topography, and in the same kind of a topography, another patient may have an epithelium of 50. So that just throws you by 20 microns, which is 1.5 diopter. And sometimes when you do a trans PRK and you don't understand why do you have a hyperopic or myopic shift, epithelium is the answer. And regarding the patchy epithelium, again, at this point of time, many companies are working on it, but only Schwind is the company where it allows you to customize the epithelium according to the zones. But otherwise, uh, Alcon, Zayas all have one standard PTK approach. So if you're not confident on the epithelial thickness or if you have a patchy one, then go ahead with a manual removal. Again, there's a debate on alcohol assisted or manual debridement. It again, I still feel that what works best in your hand, you should do it. So if you're comfortable with alcohol based debridement, it gives good results, yes. Then and the healing may be a little slower, but it does give you good results. And if you're okay with manual debridement, that's also fine. So what works best in your hand, you should go with that.
Ma'am, and do you also have any other input on the medications that you would give your patients to enhance the epithelial remodeling after PRK? Do you give right now there's a company which is coming up with vitamin D drops, no, for the Theotius D, trehalose containing eye drops. What is your inputs on that, ma'am?
So we heavily believe in vitamin D use and healing post PRK. However, vitamin D topical has its own set of drawbacks. So it shouldn't be started right in the beginning. Something what has worked in our practice for a very long time is cyclosporin.
Okay.
For two reasons. One is, yes, it reduces your inflammation, and because it reduces your inflammation, the epithelial remodeling is much much more controlled compared to that of uh, any other drugs. And we have seen because the epithelial remodeling is much more controlled, the chances of regressions or pseudo regressions because of epithelial remodeling are very minimal. So I am a very good believer of cyclosporin post PRK surgery. But yes, when it comes to haze, vitamin D based drops or now losartan based drops work very well.
Right. The other thing I also tell my patients who are going to undergo PRK is that they might see 6/6 in 2 weeks, but it might not be a very crisp 6/6. So I think it's important to put this point across preoperatively. So even though they might see 6/6 because the epithelium is not that regular yet at the end of 2 weeks, it takes its own time. The sharpness, the contrast sensitivity, etc., everything can take even up to 2 or 3 months for them to achieve the full contrast and sharpness that they might want to achieve with the laser. So I think that's something to keep in mind. Zain, any points to add here before we move into the next talk?
Oh yeah, hi. So Sandeep very well elaborated. All the points are well taken. So you showed trans PRK as well as alcohol-based epithelial removal. So, in your practice, which is your preferred choice? Because we've just discussed about the drawbacks of doing a trans epithelial PRK. So, what is your take on that?
So, so personally, I would always prefer alcohol-based epithelium removal because just that I'm more comfortable doing that. So I believe what like as we discussed, what works best in your hands, it's good. So although Streamlight also has very good results, but we do not have an epithelial mapping system. So I believe the just to go ahead with a two-step procedure rather than going for epithelium removal with the laser itself, because in the peripheries you see the because of the laser which is giving onto the peripheries because of the epithelium, and the epithelium also gets thickened in the periphery, so the ablation would be lesser than intended, is I think what I think.
Any specific indication where you would want to do Streamlight?
uh,
So
Streamlight,
basically,
like
I th
in the retreatment patient, so we can go ahead with the Streamlight only because we don't want to expose the flap. uh,
so your choice would be this manual
yes, Streamlight,
removal.
yeah.
Okay,
Yeah,
then so yeah,
yeah, we
let's move
can
on
go
to
ahead.
the next talk now. So it's my pleasure to introduce Dr. Lippi. So she's an executive member of YOSI currently. She's done her MS and her FAICO in refractive surgery. She currently works at ASG Eye Hospital. She's also the team lead in the cataract focus group of YOSI and a very avid participant in all of the Yo events. She's won runner-up in the YOSI Journal Club, won the Best Surgical Video at the Innovation category at ROSCON, and has delivered very nice presentations at regional, state, and national conferences. And now we look forward to her talk on how to perform and execute the perfect LASIK. Over to you, Dr. Lippi.
Thank you, sir, for the opportunity. Let me just share my slides. So are my slides visible?
Yes, you can go ahead.
So good evening, everyone. I will be discussing LASIK today, and I will be covering the procedure, techniques, and patient selection. So as we all know, LASIK is laser-assisted in situ keratomileusis. Keratomileusis means carving onto the cornea. And for reshaping the cornea, we need to have a precise laser. So in the laboratory, IBM laboratory, Srinivasan used Excimer laser to actually etch or ablate the human hair. And we can see how precisely it has been ablated. So Excimer laser has been used since then for corneal refractive surgeries. It has a wavelength of 193 nanometer, and it does not have any collateral damage. This laser works on the principle of photoablation, which means that the intermolecular bonds are broken and the cells which are separated are evaporated. So before moving on, let's just have a brief overview about the corneal profiles. Normally, the cornea is prolate. That means it is steeper in the center and flatter in the periphery. Whenever we are doing a myopic LASIK, we are flattening the center of the cornea, making it an oblate cornea. And in hyperopic LASIK, the peripheral ablation is done and makes the cornea steeper in the center, leading to a hyperprolate cornea. So whenever a patient is coming to us for any refractive procedure, the question arises, is the patient fit for refractive surgery? And if yes, which surgery is best suited? So for that, we need to have a detailed examination and detailed visual acuity assessment. We need to document the uncorrected, corrected, as well as near vision, manifest in cycloplegic refraction, as well as the power of glasses should be checked so as to know the stability of the refractive error. So FDA-approved correction ranges from -12 diopters, hyperopia of 6 diopters, and astigmatism of less than 6 diopters. So an ideal candidate is somebody whose age is more than 18 years and has a stable refractive error, which means that there is a change of less than 0.5 diopter of mean spherical equivalent over 1 year. The patient should not be pregnant or lactating or planning to conceive for 1 year, free from systemic or autoimmune diseases, and we should set the realistic expectations. Like, for example, if the patient is coming and has amblyopia, we should counsel about the best corrected visual acuity post-procedure. If we should counsel about the need for presbyopic glasses in future. So there are various factors influencing the decision making. I would describe all of them. So the one thing I would like to highlight is the occupation. We need to ask the patient the purpose of refractive correction, whether it is cosmetic or whether it is for any medical purpose. As Dr. Sandeep has mentioned, in contact sports or arm professionals, flap-based procedures are slightly risky because of the chances of post-LASIK flap displacement. So coming to the history, prior use of contact lens should be elicited, as there should be an off contact lens period for at least 3 days to 1 week in soft contact lens users and 4 weeks in rigid contact lens users. Of course, the history that has been described by Dr. Sandeep, all these are contraindications for LASIK. Coming to the clinical examination, we should check for the intraocular pressure, near point of convergence, position of lids for any ptosis, tropias, or phorias. Now, assessing the orbital anatomy is very important. As deep-set eyes and narrow palpebral fissure, it becomes difficult for the suction ring application and the chances of intraoperative suction loss. So ocular adnexa should be examined thoroughly. Any blepharitis, mebomitis, conjunctivitis should be treated first before going for LASIK. Lenticular examination is very important, as early nuclear sclerosis or any lenticular opacity would lead to suboptimal visual results, and a detailed fundus examination, including the peripheral examination, as all the degenerative changes should be lasered first before going for LASIK. As we all know, dry eye is a very known complication post-refractive surgery. So a detailed dry eye workup should be done in all the patients, and dry eye should be treated first. Now, coming to the investigations, I won't go into the details, but corneal topography should be done in every patient depending on whatever modality is available in your center. We should basically rule out the ectasias or form frustrate keratoconus in which LASIK is contraindicated. Pupillometry and angle kappa measurement is important as we have to counsel the patient for the risk of post-operative glare and halos. So these are some of the high-risk corneas. They have already been mentioned in the previous talk, so I'll just move ahead. So corneal biomechanics is the recent modality which has come across, and Corvus ST is the new device where we can assess the corneal tensile strength. It will tell us about the subclinical keratoconus and the chances of ectasia in future. Wavefront analysis by using aberrometers, if you have access to that, will give us higher order abrasions and help in planning the LASIK ablation profiles. These are various ectasia scores. We should check the ectasia scores and we can predict corneal ectasia after LASIK. So coming to the corneal cutoff parameters, RSBT is calculated as the central corneal thickness minus flap thickness and the depth of ablation, which is calculated with the Millernin formula. And RSBT, I personally take more than 300 micrometers. Percentage of tissue altered should be less than 40%, and it is calculated as flap thickness plus ablation depth divided by the central corneal thickness. Now, the post-LASIK keratometry is very important, as we know that in myopia cases, it is 0.8 diopter per diopter flattening, and in hyperopia, there's steepening of 1 diopter per diopter of correction. So it should be 34 to 49 diopters post-LASIK. So whenever RSBT is more than 300, PTA is less than 40%, and post-op keratometry is within 34 to 49, we can go ahead with a cornea-based procedure. Now comes the various ablation profiles. So the machine which I am using is Wavelight TX500, and there are various like wavefront optimized, guided, and topography guided, which is popularly known as Contura. So before understanding, we should have a basic knowledge of what a wavefront is. So as we all know that our eye is not a perfect optical system. There are rays which go off track, and these rays which are going off track will lead to abrasions in the eye. Now, these abrasions can be lower order abrasions, which can be corrected with the help of spectacles, or higher order abrasions. Together, they consider the wavefront. So wavefront can be computed as corneal abrasions, internal and total abrasions, and they are measured in terms of root mean square values or RMS values. There are various aberrometers, like we can measure it on Pentacam, Zernicke analysis is there, or with the help of eye trace, which is a ray tracing aberrometer. Now, understanding the wavefront is important, as we know that nowadays LASIK is just not giving 6x6 vision. It is also about the quality of vision. So there are various ablation profiles. So let me just briefly describe the cosine effect. So whenever the laser is fired onto the cornea, the central portion, the laser spots are smaller and the fluence is full. As we move towards the periphery, the spot sites become oblong and the fluence decreases, leading to spherical abrasions. So this is machine-induced abrasion. So in conventional method, all the lower order abrasions, that is the spectacle correction is given, but it does not consider the machine-induced abrasions. So in wavefront optimized, the optimization in the machine is done in such a way that it will not induce newer abrasions. Whatever abrasions are there in the eye will be there. In wavefront guided, all the total pre-existing corneal optical abrasions will be reduced, and if the abrasions are predominantly corneal, we will move ahead with a topography guided. So to summarize, if the higher order abrasions are less than 0.4, we will go with wavefront optimized. If it is more than 0.4, we will go ahead with wavefront guided. If the corneal abrasions are dominant, we will go ahead with topo guided. Now, if the higher order abrasions are less, but the repeatable scans are not acquired, we will still move ahead with wavefront optimized. And if the corneal abrasion scans are acquired, we will go ahead with topography guided ablation. Now, this is basically for Contura. Topolizer acquires all the corneal parameters, and the data is transferred to the laser unit for treatment planning. Then all the treatment, this is the data which has been transferred from the topolizer, and we have to enter the subjective refraction. This is the measured refraction which has been entered, and according to the nomograms, we have to modify the refractive error, and this is the ablation profile which includes lower order as well as the corneal abrasions. So coming to the procedure, we have to do preparation, flap creation, reshaping the cornea with the excimer laser, and then flap repositioning. So preparation includes machine preparation, calibration, data entry. Optical zone should be kept 0.5 millimeter larger than the scotopic pupil size. Coming to the patient preparation, topical anesthesia is instilled. Instructions to the patient is given that they have to target on the green light, and flap marking is advisable, so as to be cautious during intraoperative complications like free cap. Now, flap creation can be done with the help of a microkeratome or a femtosecond laser. Microkeratome, which I use, is Moria SBK1 use, and it is a translational microkeratome which gives nasal hinges. There are rotating systems as well with superior hinges. Now, these are the various ring sizes. So the ring size can be calculated with the by looking at the horizontal K values. So what I do is, if the keratometry is slightly flatter, that is less than 41, I would go ahead with 0 with 8 size, and if it is steeper, I would go ahead with 2 with 7.5 ring size. So this is how the suction ring is applied onto the cornea, and we should check the microkeratome blade before putting it onto the cornea. Now, once the vacuum is stable, the microkeratome blade is proceeded forward and then backward. And then the suction is released and the ring is removed and the flap is lifted. After that, drying of the flap is done, and then the excimer laser ablation is done onto the stroma. Then all the laser debris has to be washed from the bed as well as from the flap side. Now, flap has to be deposited back, and the interface wash is done. And then the final step is flap repositioning, which is done with the help of Merusal sponge. There's ironing out of the flap is done, and then the margins are dried off. Now, another modality of creating a flap is femtosecond laser, which is popularly known as bladeless LASIK. So a femtosecond laser basically works on the principle of photodisruption, which means the formation of cavitation bubble, which coalesce together and form a cleavage plane. Now, this is how the patient is made to lie down on the femto platform. He's instructed well. The data is pre-fed into the machine. There are side cut angle, flap diameter, hinge position can be customized in femto procedures. So this is the suction ring which has to be placed. So this is the video. I have taken it from internet. So this is how docking is done, and the creation of canal, flap, and the side cut is formed. So after that, the patient is transferred to the excimer platform, and then the corneal flap is lifted off. After that, the entire process is same as that of a microkeratome LASIK. Excimer laser is, the cornea is ablated with excimer laser, washing is done, and the flap is repositioned. So the flap creation with microkeratome and femto, the difference is in the shape. It is meniscus shaped in microkeratome and planar in femtosecond, making it better adhesion, giving it better adhesion. Also, the hinge side can be customized in femtosecond laser according to the ablation profile. So the post-op treatment includes topical antibiotics, short course of topical steroids, preservative-free lubricants, and a careful evaluation of the flap on post-operative day 1. Patient can be asked to resume the normal activity from the next day. So we should choose the right patient and the right procedure in order to have the right outcome. Thank you.
Thanks, Dr. Lippy. Very elaborately described. You showed a very good microkeratome LASIK as well. So, before we take comments from Dr. Pooja, a couple of things is that related to the flap repositioning also, that is something that is extremely important in LASIK, which I think was missed over there. The flap repositioning has to be very standardized, in every situation. And we should avoid trying to overhydrate the retracted flap, because that tends to swell up the flap and then it creates an epithelial gutter around. And that gutter then forms an nidus for epithelial cells to grow if we are doing a relift later on. So that is something that is important. Apart from that, very well, you showed everything very well, and the importance of understanding that a good microkeratome LASIK also will give you excellent results in today's time. I don't think, as Aditya said, I don't think it's going to go off in the next few years. LASIK is here to stay for many, many years. Yeah, so Dr. Pooja, your comments on LASIK overall and the presentation. Yeah, you're muted, Pooja.
I think wonderful presentation, Lippy. All the points were very well covered. Only thing I think Dr. Sandeep did cover is about the pre-op examination. One more thing you have to keep in mind is the post-op care also. Sometimes in LASIK patients, you see nowadays a lot of meibomian secretions intraoperatively. So whenever you see a lot of those floating secretions, which you don't, you're like, where is this coming from? Always, I think your steroid regimen for the first few days should be a little bit on the higher side, starting on the day of surgery, because these are the patients who have higher risk of DLK compared to that of other patients. And I have seen few patients where whenever there are excessive secretions and if you don't give extensive steroids on day 1 or 2, they go in a quite a lot of exaggerated DLK. So DLK is one thing which you have to keep in mind. And one more thing is the microkeratome flaps are very good. They're always easy to relift, but sometimes they are also very easy to get displaced. So a lot of times I see that patients do not come for a follow-up on day 1, or sometimes they just see like that and run away, especially in rural areas. You have to encourage the patients to come for a follow-up just to make sure the flaps are in place. So these are the only few things I would keep in mind.
Yes. So thank you, Dr. Lippy. So just like Zain said, no, there's one more thing I'd like to add about the flap repositioning. So what I do is I follow Dr. Dan Reinstein's three-step protocol for flap repositioning to avoid microfolds. So one important thing is to avoid overhydration. So a lot of beginner surgeons we see, they're very anxious about having interface debris, and after putting the flap back, you start overhydrating, you move in a circular fashion, and you uh, inflate the flap. It becomes like a steak. It becomes so thick, and then it's impossible for you to know whether you've replaced it currently. So what happens if you overhydrate the flap is you push it back, but then you think is even, and then next day after the flap detourges, you see on slit lamp, you'll see flap crunch. You'll see microfolds only towards the nasal or the temporal side. So what we do is we just put the flap back. We use a 27 gauge cannula on a 5 ml syringe. You push out the fluid in a very forceful manner. That is, you overpressure it. You get the cannula under the flap. In just one singular motion, you just wash the flap out. That's it. In just one swipe. You don't need to do multiple swipes. So that itself, because of the Bernoulli principle, will remove all the debris, and there's no need to overhydrate. If you don't overhydrate, you will not get any microfolds or flap crunch. Following that, shift the patient straight out of the OT to the slit lamp outside. Outside the slit lamp, I examine them, and then I see for any macro adjustments. If I see the flap is one way or the other, I macro adjusted there because it is still hydrated enough for me to adjust with a Mercel sponge. Following that, they go down, they get the vision checked. The vision check is just as a gross vision check, not for the vision check in particular, but we allow the flap to dehydrate and it starts to position and sit well. Then I bring them to my clinic. Then I stain. stain very hard with the fluorescent, and then you look for microfolds. And then you'll be surprised that you can iron these microfolds out with just a Merosol sponge. You just do radial strokes from the center to the periphery. You can iron out those microfolds. And then the next day we do it again. So this is the 3-step protocol. And if you follow this, you'll be very surprised that you will not get any microfolds at all. And you won't know that there are microfolds unless you stain. So we'll have to make a habit of staining every patient immediately post-procedure. And microfolds don't just affect quality of vision, they might also affect your refraction as well. You'll be surprised to see sometimes a patient with a -1 cylinder, we just iron out the flap and remove the microfolds, it goes almost to plano. So following this standardization is, I think, very important. You might already be getting great results, but this just gives you an edge and pushes your results even further and gives you very happy patients.
And just to add to that, the microfolds, apart from the microfolds part, the marking is extremely important. So some people, would recommend that if you're doing a femto LASIK, you need not mark. But I would say marking is important because that marking also helps you align the flap intraoperatively. So even if you're doing a femto, I would say that, at least as a beginner, you mark and you try to align the flap best to the marks post-surgery.
Very true. Even though I don't do MK anymore, all my femto flaps I still mark. Yeah. Okay. So let's move on to the next talk now. Now we have our keynote address by Dr. Pooja Kamar that we are all very excited to hear. She is going to speak to us about personalization in refractive surgery, shaping the future of vision correction. Over to you, ma'am. Ma'am, I think you are muted, so can you just...
Sorry,
Yeah.
So thank you, Aditya, and thank you, Zayan, once again for inviting me here. I'm just one of you, and I'm also still learning. So just going to be sharing some of our experience. Few of the slides, if they're repetitive, I'll just skip them, but otherwise I'll just share a different perspective of the presentation. So we all know that myopia is on a rise, myopia, hypermetropia, astigmatism, and the cosmetic corrections for our face, our body, our eyes are also on the rise. So we are seeing an increasing trend of refractive surgery. And there are plethora of procedures, like it started with PRK, LASIK, microkeratome LASIK, then you have femtosecond LASIK, then in LASIK you have topo-guided treatments, wavefront guided treatments, now you have ray tracing guided treatments, and then you have lenticule procedures and phakicyles also. So as I mentioned in the beginning of the webinar, I think choosing the right refractive surgery is the key for any of the patient. Excimer surgery is not the only thing, but choosing the right procedure is the key. So LASIK, yes, it does. It is quicker visual recovery, lesser post-op discomfort, and lesser incidence of infection, inflammation, or haze. And we do have options of microkeratome or femtosecond based flaps. We have wavefront guided or wavefront optimized treatments, and then we have topo guided treatments. So wavefront guided treatments are something which takes care of the aberrations of the entire eye, inherent and induced, and it corrects the entire thing, which of course has increased precision and personalization, and it reduces the glare starburst halos with improved results in high resolution with abrometers. However, it does have a small challenge with the pupil, and especially Indians having a smaller pupil size. We do have to be a little bit more vigilant on how we choose a wavefront guided LASIK. I'll come to a little bit details of each of it, but just giving an overview in the beginning. So that's how the wavefront guided LASIK is, but then it had challenges and it was becoming difficult for the refractive surgeons to perform in some of the countries. So then came the wavefront optimized, not it's aberration free or just a smooth treatment where it just takes care of your spherical aberration and does not individually treat the optical aberrations. So if your patient has a minimal aberration of the eye or um, of the cornea, then and just a simple refractive error, this is a good treatment. However, it's not customized to the individual eye, but you can perform on any of the machines. Is what you have to understand. So that's the 70% of your cohort, but the rest 30% of the cohort is your either wavefront guided treatment or topo guided treatment. So then after wavefront guided treatment, people went on to normal LASIK, like a wavefront optimized, But then, of course, it was not addressing the aberration. So then came the topo-guided LASIK, and it takes care of the corneal or topographic irregularity. So it again increased the precision and personalization. But yes, there was a small challenge on mismatch of the cylinder. So we do have now advanced softwares. Zion has one. There's a 4CDs, there's a 3Z, which can take care of these cylinders and determine the axis what should be treated. So again, this is one of the very viable option for the patients. And you can either choose to treat all the aberrations, or if you have a machine where you can, the world is moving towards customization and precision. You can selectively treat, select what aberrations to treat, what not to treat. So that also you can do it for your topo guided or wavefront guided treatments. So you have to keep in mind which technology are you're using, and choose accordingly. And apart from that, we do have Smile. Of course, it is you can call it Klex now. It's increasing the uh, it's increasing the popularity of like how you transition from ECCO to SICS to phaco. So but still SICS comes as a good tool at times. Same thing is with LASIK. So lenticular procedures are probably the way forward, but that doesn't mean LASIK and PRK are not going to be here. And the advantage here is it's flapless. So PRK is not the only flapless procedure. Now you have Klex procedure also, and it's quicker recovery in terms of dry eye. And you do have Klex procedures from Visumax, Schwind, J&J, and Zimmer, which gives you as an option of Klex procedures also. However, you have to think like a refractive surgeon, and whenever you think like a refractive surgeon, you have to think from optics and imaging point of view. You have to think from the healing point of view, and of course the art of refractive surgery, where Dr. Sandeep and Lippy has already mentioned what are the good points to make sure that your surgery is effective. But with plethora of treatments, how do we choose? You have to first divide between what is the age of the patient, and if it's below 40, then you have all these options. And you will do a phakic for the patients if it's not suitable for laser surgery. If the ACDs are more than 2.8, the RSB is more than 300, and your endothelial cell count is good. So this is the first category. If your patients are not eligible for laser surgery, you rule them out, give them an option of phakic IOL. However, if the patients are eligible for laser surgery, then again, Sandeep has covered this. When do you choose a PRK? And you have all the technologies which can offer you a PRK procedure as well. So PRK is now evolving, and we are evolving towards trans PRK, which is no touch, no cut technique. It leads to lesser tissue dehydration, quicker procedure. Less incidence of haze and pain because of the faster recovery, because the epithelial edges are very well precised. Less chances of hyperopic shift if you have your epithelial maps in check, and better ablation profiles. So now the trans PRK can be done with two machines right now. There are other technologies also you can do trans PRK, but it's two-step. These are the only technology where you can do one step at a time. So you have your Schwind Amaris and Alcon Wavelight, a Smart Surf Laser, or a Streamlight, with which you can do a one-step PRK also. Always make sure that whenever you're doing sorry, the video is not working, PRK procedure, after the PRK procedure, anytime if your ablation is more than 2 diopters, use mitomycin C 0.02%, 10 seconds for every diopter, and that's how you intraoperatively minimize the haze incidence. However, there are two fears still, pain and haze. So for pain, one thing which works very well is anything cold. Your cold BSS before and after surgery works very well. And when you are applying a contact lens for this patients, a cold BCL works very well. And when you use cold BSS or cold BCL against the normal room temperature BSS or BCL, the pain scores reduced to as minimum as 0 or 2. And this works very well for children, because especially in cross-linking patients. This is not just for PRK, but for cross-linking also. So this works very well when it comes to doing your trans PRK. So this induces the incidence of pain, and then if still the patient has on the post-op period pain, then you can always use a cyclopentolate or oral painkiller to take care of it. But otherwise, this takes care of the initial pain period you have. Now, haze is also one of the most important and the most dreaded feature of outcome of PRK, and that's why it went kind of out of vogue. So why does haze happen? It's because of the pre-op inflammation the patient has, which can be contact lens intolerance, MGD, or irregular epithelium, or known dry eye. So if there is a pre-existing inflammation, then these patients are at more risk of developing haze. And we have developed this nomogram where you can predict, examine, treat, follow up, evaluate, and if there is a late post-op haze, you can give the patient a chronic treatment with which the incidence of haze reduces quite effectively, and patients have good outcome for this protocol what we use for the patient. So this works very well for pain and haze, which are the two dreaded uh, enemies of PRK. Now you have smile and LASIK. You can divide it like this. If it's a normal topography, minimal or no aberrations, a good mesopic pupil, and a good angle alpha kappa. If they are into contact sports, encourage them for smile. But if they are not into contact sports, if the cylinders are optimal, then encourage them for LASIK, and you can do a wavefront optimized LASIK. Now, this is how the smile works. Now you have other technologies also, but this is how you dock the patient. You can see the green light is helping you to center the laser ablation on the pupil, and then you deliver the laser. First, it creates the posterior cut, and then it creates the anterior cut. It takes around 20 to 25 seconds. Now with 800, it's reduced to 8 to 10 seconds. So the cooperation of patient is much better in 800 now. And the laser fired is similar way. And now this is the anterior plane being created, and then the side cut. So once it's done, you just open the anterior and posterior plane and go ahead and dissect the planes, and then you remove the lenticle. And do have uh, more advanced techniques where you don't need to dissect anymore. You can just do a lenticuloschisis, or you can do a peel technique where you just do like a rhexis. You can grasp the lenticle with a forceps and just remove it without dissecting it. So it's becoming much easier as well there when it comes to CLEX procedures also. Now, how to choose between the wavefront guided or topo guided LASIK? This is a simple algorithm again. If the patient acceptance cylinder is low than corneal cylinder, go ahead with a topo guided LASIK. If it's the other way around, go ahead with a wavefront guided LASIK. It's not that you can't do either, but this works very well if your machine offers both the treatments or either of the treatment as well. So when it comes to cylinder, yes, you get cylinders which are matching with your topographies. This is the patient cylinder, this is the topography cylinder, so they are matching. There are times when the topography cylinder is higher than the patient cylinder, or vice versa. So you again, aberrations, the cylinders don't just come from a cylindrical astigmatism power, but it's a composition of coma, trefoils, defocus, and other aberrations as well. So you have to understand that. And if the patient has a lot of aberrations on the cornea or internal part of the eye, then you may have a mismatch in the cylinders. Even the lenticular cylinder plays a very important role in this. And if you have that, then you have to apply a nomogram, and you can adjust the cylinder with the patient and measured cylinder, which is the topography cylinder, balance it out and treat it. And that's how it works. This is a simple example of how we do it. You do have to do a zero rule, then you have to see if there are internal aberrations or not, and what is the total eye aberrations, and then accordingly balance it, so it will help you. So it's a whole new lecture in this, but this is a 3Z nomogram what we have developed, and there's a software, so it helps you treat it without any a lot of calculations. Something which is very interesting, which is coming up, is ray tracing based LASIK surgeries. And you can call it Innovise or Wavelight Plus right now. Schwinn has ocular wavefront treatment. So what it does is it takes the aberrations of the entire eye, the full optical system, and it has an AI-based nomogram through which it calculates a unique ray tracing treatment plan for every eye. So basically, it's more personalized approach, and it not only takes the whole eye aberrations into consideration, but it also takes your optical biometry, corneal topography, the corneal wavefront, and the ocular wavefront aberrations into check, and then it gives you a treatment. So it's quite interesting what's coming up. Very few installations in India, but it's soon going to be um, FDA approved. So the challenge is what you have with mismatch of cylinders in your patients is going to reduce when it comes to this. So you can't really say it's an AI based algorithm, but yes, it has a unique ray tracing treatment plan that is optimized to deliver the more personalized procedure possible for each eye. So that's called as Innovise Wavelight Plus, and that's the way forward. And you can see that there is a refraction, the patient's refraction, what is calculated from the Innovise. It gives you the topographic cylinder, it gives you the wavefront refraction, and based on that, it calculates the final treatment plan of what you want to do for each of the patient. Schwind, Pyramis, if you have Schwind and if you have Pyramis, it's also similar. It's a Placido-based topographer with aberrometry, which also takes into consideration static and dynamic pupillometry. And that's how the pyramid wavefront sensor works. And that's how it's also customize a wavefront guided treatment for every eye in a unique way. So it's not just one machine, but different machines as well. Now, if your patients are above 40 years, if they have a good tolerance test, the DLI is normal and the normal topography, you opt for a monovision LASIK or Presby LASIK. But if any of it is deranged, then you go ahead with a refractive lens exchange. And in monovision LASIK, it's simple. The near dominant eye, you undercorrect and leave some amount of myopia. And the distance dominant eye, you correct it fully. That's how the power is corrected. But however, there are technologies which gives you an option of Presby LASIK also, like Presby Max from Schwinn, Presbyopic from um, Zeiss, and now you have Reed from Alcon also, and Custom Q and SupraCore are also there. So there are a lot of options when it comes to Presby LASIK also, but counseling is the key. And this is a small algorithm which has been published by a collaborative work from Dr. Rohit and Dr. Sheetal, and this is what happens, or how you choose the Presby LASIK for the patient and what it does on the cornea. So this is also possible when it comes to it. And if not, then do know that refractive lens exchange is possible. Now, it's not only about the laser-based surgery. Sometimes you do not know that why the outcomes are not optimal, and also you do not know sometimes how to choose your patient for laser surgery. You do LASIK, you do PRK, you do phakic IOL, or you do CLEX. So not much of a famous thing, but biomechanics is coming into picture, and it helps to us to predict which patients are at potential risk of developing post-refractive surgery ectasias. And you do have Corvus for the same. You have CBI, anything in the area of 0.5 or more, that means it's suspicious. Then and this is what you have to avoid. Anything 0.5 or more, you have to avoid doing a LASIK procedure on them. TBI also is a very sensitive tool, which is a combination of topography and biomechanics, which also helps to better detect the early ectasias, and anything in your 0.5 or more zone, that means avoid it. Sometimes in Indian eyes, they too don't work well. So then you have a stiffness parameter, which negates the effect of IOP. So anything less than 100, that means it's a weaker eye. Anything more than 100, that means it's a normal biomechanical parameter. So biomechanics does come into picture quite a lot. Now, you do have two similar topographies, but different biomechanics, and you don't know what, it's a little confusing. So we are developing this AI based software. Again, it's available not commercially, but for people who have Pentacam and Corvus for this point of time, and it uses finite element modeling along with AI. What it does is it dissects your cornea into very small, simpler parts called finite elements, and based on that, it gives the Young's modulus for every small element of the cornea. So it gives you a better estimation of corneal stiffness. It creates a mesh, then you can, and more than giving a Young's modulus pre-operatively, it can help us predict what will be your corneal stiffness post-surgery. So you just have to add a little bit of an algorithm where the how much laser ablation is going to happen is added to this algorithm, and it will then tell you post-operatively what is going to be your corneal stiffness. So it's a combination of tomography, biomechanics, finite element modeling, and AI, with which we have created the software AccuSim, and it does give you an algorithm. Again, It's a very good algorithm. Less than 90 means weaker cornea, 90 to 120 normal, more than 130 stiffer. And based on that, you can choose whether you want, like everything is normal, go ahead with any procedure. Anything abnormal, you choose a smile extra. More on the weaker side, you choose PRK extra or a phakical, or if everything is bad, then you choose a phakical. So basically, this AI-based tool will tell you which procedure to choose for your patient as we move on. Now, every person is unique, but what about their eyes? We are going into an era of CLEX procedures. This is a similar looking topography, similar thickness, everything looks similar and similar refractive error, same machine, same energy is used. But day one, and this is a very big dilemma in CLEX procedures, uh, first patient has 20/20. Both the patients have 20/20, but the first patient has poor quality of vision. The second patient has good quality of vision. So it's like called 20 wow and 20 not so wow vision. Now, why everything is similar, but still the outcomes are not similar? So let's rewind. If you see here in the first eye, you can see that there are a lot of these white spots, which is known as OBL, and spreading beyond the lenticule side cut. If you see here, it's quite well precised lenticule side cut. You can see very minimal white spots, especially in the edge, and it's not spreading over the lenticule side cut. And these are known as OBL. So you do see this variable patterns of OBL, and Aditya probably would be able to comment more. If you have this variable patterns of OBL, and when you try to dissect them, higher the OBL, tougher the dissection, easier the lower the OBL, easier the dissection. So here I'm done in hardly 10 seconds, and here I'm still struggling. So that makes a very important, that plays a very important role. So why is it that we started looking into biomechanics, and what we found out was stiffer the cornea, basically more the biomechanics, stiffer the cornea, you have a higher effort of dissecting those lenticules, and that's when the day one vision is not so optimal. And you do have this indices like Corvus, ST, CBI, SPA1, and AccuSim. So as I was saying, this is the algorithm which tells you which surgery to choose, but this is a normal stiffness. The difference here is the first patient has 83 newtons per meter, the second patient has 115. So you can see it's a very, very, very stiff cornea. And if I do a dissection in this, it's going to have not so wow vision on day one. And it matches the grade of OBL, the grade of dissection does match with TCT, BAD D, CBI, SPA1, and higher the grade of dissection, higher the grade of OBL, tougher the grade of dissection, and poor quality of vision. And this is also an AI-based work which we have done to predict which eyes will have good or wow vision on day one and which eyes will not have wow vision on day one. So it does help to correlate. So if you know that you have a stiffer cornea, probably choose a LASIK or modulate your energies to have an optimal dissection for a better quality of vision. And this is true, and this does happen because when you dissect a lot, there's a lot of activation of this keratocytes and myofibroblasts. You can see how patchy, this is a confocal image, how patchy these corneas are, and it takes a month for it to come back to normal. So a lot of times for CLEX procedure or smile, you've heard that, my patients are happy, but they take 1 month for it to come back to normal. So this is the reason. Whereas this is the patient again on day one, you can see it's a good looking confocal, no white patchy surfaces like myofibroblast, and at day one only they are wow. So they're not taking time for it to come. So you do have to look at biomechanics as you move forward when it comes to CLEX procedure also. Now, in keratoconus also, Excimer laser does play a role, and this is a very wonderful algorithm of when to do a topo-guided PRK with cross-linking and when not to do a topo-guided PRK, because topo-guided PRK does reduce your aberrations, your need of glasses, or it does make your surface more smoother for contact lenses. So again, it's a way forward. So you have to start learning about a topo-guided PRK in a keratoconic eye, when to do, when not to do. One of the things Aditya did ask me to cover, it's very futuristic, but it's a very good, I would say, toy in our clinic, where you have a phoropter. You have a phoropter of aberrations. Usually you have a phoropter for your refraction. This is a phoropter for aberrations, where you can modulate the aberrations and check which aberrations the patient is comfortable with and which aberrations the patient is not comfortable with. And this works very well in a decentered cornea or an irregular cornea, where you can take the patient up. It's a Hartmann check or barometer, and it helps to modify the aberrations. See that you can actually modulate on the spherical aberration, off the spherical aberration, on the coma, off the coma, and ask the patient what helps them see better. So, it will help us to improve the performance of extended depth of focus because it's spherical aberration driven. It will help us to identify which presbyopic laser treatments patients would not be happy or which ones would be happy, and of course for irregular corneas as well. So this is a patient, commercial pilot, complain of blurring of vision, glare, difficulty in focusing, everything which can go wrong, history of RK. And this is the refraction the patient has, of course, with near eye, and it's a 16 cut RK, so you know what happens in this patient. And you can do a regularization, but it's quite tricky, and especially for a commercial pilot who has a very a very high demanding. So we did a adaptive optics for the patient, and it did tell us that if we keep the SA on, or if you keep the coma and SA off, what would be the aberrations treated. So we kept the SA on and coma off for this patients, and this is what happens. It tells us the quality of vision, the residual error, and everything with what aberrations you'll treat. So we've kept the SA, coma, everything off, and this indicates improvement in the corneal regularization. So we replicated the same thing from the adaptive optics to the Schwindner-Maris. We modulated and we customized the aberration. The ones which you see in gray, the machine is not going to treat, and the ones which you see in colors images, the machine is going to treat. This will have a better regularization of the surface, better correction of aberrations, and also it will minimize the tissue ablation what we have done. And this is what we got. This is what he represented with. Was his day 1 month outcome. You can see the non-corrective itself is 6.9 with an emetropy, and this is how the topography looks like. So it does help in customizing the refractions and selectively treating what aberration to treat, what not to treat in such complicated cases. And I corrected this. I don't need to go into this again. And yes, the laser ablations can also help us in customizing the scar patients. You can see it's a localized scar. So you've just done an excimer laser for this part. It's called a scar trek, where you are not doing an entire PTK but a selective PTK in the region of scar. And this is his 1 month outcome. You can see there's no induction of hyperopic shift because we have not ablated the healthy tissue, a regularization of topography, improvement in quality of vision, and a good OCT with removal of scar. So yes, excimer lasers do help us here. Refractive surgery does sound simple, but it is not. And it's like they say that, every day you have to learn something new or improve your skill by 1%. So where you will reach to treat this complicated cases and choosing the right laser. So today you may be this, but you have to aim on becoming this after 1 year for all the patients. And the goal is not to learn an instrument or a technology, but a refractive surgeon's goal should be to become a musician by itself. Thank you.
Thank you so much, ma'am. I think that was absolutely amazing, as is consistent with all talks that we hear at Narayana Netralia. There's something so innovative coming up that we've not even thought about. So I'd just like to comment on the role of corneal biomechanics and the corvus. It's very interesting because I do believe that we are sometimes missing things out by just doing a corneal topography alone. Last 2 years of the 1,700 smile cases we've done, I've had 2 cases of ectasia that came after 1 year. And both of them were low myopia, normal cornea thickness. They were not the cases that you would expect ectasia to happen. All the cases I treated for high myopia, who I was a little nervous about ectasia, they're doing well. But this patient was 520 cornea, normal topography. For a minus 1.5 diopters, she developed ectasia. So I think for things like this, we need to look further, dig deeper. But I do remember you mentioning, ma'am, that sometimes the corvus can also overestimate the cornea's weakness. And sometimes you end up rejecting 50% of your patients. I'm not sure what the real numbers are, but somewhere in the ballpark. Is it accurate enough to start incorporating in your practice today?
For 10% of the cases which you had, yes.
Yeah, okay.
But yes, there are some 20% of the cases which throws you off limits, and you don't know what to do. So in Indian eyes, now we are coming up with an Indian CBI, TBI soon, so it will become more predictable. What we have been doing till now is we are using the normative range of Caucasian populations. So they are of course different. So we are coming up with Indian CBI, which will increase the sensitivity and specificity for our corneas. Until then, it's not just the CBI or TBI, but you have to take into consideration the SPA1 also and thickness also. So that's why it's a little complicated. So that's why we developed the software Accusimics, where you just put in the files. It will tell you what is going to be the post-op stiffness, normal, low risk, high risk, moderate risk. And then you modify the treatment. You do, if you want to do a LASIK, if it's low risk, of course, avoid do a smile extra or do a PRK. And if it's a high refractive error, if it's a moderate or high risk, do a phakic. So until and unless we get the Indian CBI, TBI, and SPA1, the normative data, which we've been working on with Oculus, I think you have to learn a little bit more deeper on how to calculate CBI, TBI, SPA1 all together and choose the procedure, and if not, use Accusimic software.
Right.
But as I said, it's not just now to choose the procedure, it also helps you decide what are the outcomes going to be, especially when you are doing a lot of lenticle procedures. So
Okay.
it will help you to tell, what is going to be a quality of vision on day one. Is it going to take a longer time? Is it going to be a good quality of vision day one? So it helps you to educate your patients, or it helps you to modulate your energies or your intraoperative techniques. So, see, nowadays, let's agree that gone are the days when patients like, why do you think there was a buzz of Contura or there was a buzz of Wavelight Plus? It's because patients wants 2020 or 2010 day one. And when you're dissecting, or in Smile, you don't know why it's not 20 happy day one. That's when the challenges or the uh, what do you say, the popularity of CLEX procedure reduces. So I
Correct.
think one of the factor is biomechanics, and of course the learning curve, where it helps to predict whether your patient is going to be 20 happy day one or not.
The other thing is, ma'am, when I'm doing Smile, when I have a patient who is having a little tougher dissection, I'm actually happy on the inside because
You
I
know that
feel,
it will not develop ectasia.
yeah, exactly. So I feel the collagen is stiffer, it's probably lesser chance of having ectasia. Whereas if I start dissecting and it's moving as smooth as butter, then I start getting
Vulnerable.
nervous.
But
So
with
yeah,
you're right, you're absolutely right. Tougher the dissection means you are at ease that the ectasia to develop probably nahi hoga. But on the second thing, like if you have tougher dissection, sorry, or if you have smoother dissection where you don't know whether to do an extra procedure
correct.
or not, and with the new companies coming up with this differential energies, low energies next to each other spot size. I would say I'm using silk for almost 3 years now. I don't dissect at all. I just grasp the lenticule. I forgot to add the video. I don't know why. I just grasp the lenticule. It's like it's like your femtosecond rexis
Right,
already separated. You just have to take an instrument, go and catch it. So machines like silk now don't need dissection, so you don't know in that case whether your collagen is stronger or not. And with Schwind etos you can have a customized energy with asymmetric offset, so there also you don't know. The dissections are quite predictable, so there is going to be a challenge with the OBLs and everything. So
correct.
it's a good part, but you have to be cautious which machine you're using.
One last comment from me, ma'am. Now we're seeing a lot of buzz about Wavelight Plus. Yeah, we understand it's topo guided, wavefront guided, all of that. But how different is it exactly from Contour, ma'am? What is the science and what is the marketing here? Could you tell us that?
It's a ray tracing treatment, and it's a ray tracing treatment not just of your cornea but the whole eye. So, um, not us, to be very honest, in India, because Zain has been using for a very long time and he's quite comfortable with Contura. I'm quite comfortable with Contura. So we've found a sweet spot. But a lot of surgeons across the globe, they're
Mhm.
very confused when it comes to this mismatch of cylinders, what to treat, what not to treat, and sometimes softwares like Sport Cities or ours also don't work. And because they have larger pupils, again there's a different challenge of the zone and everything. So what Wavelight Plus is doing is, what they claim is that you're not going to need any of these softwares. They have a ray tracing module where based on your pupil size, your corneal aberrations, your axial length, and the whole eye abrometry, the machine will calculate a treatment and tell you. So you have to use less of your brains and just go and fire it, is what they're claiming. But one of the challenges we have in Indian eyes is the small pupils. You need a minimum pupil size of 4 millimeters. So we've had
Okay.
Wavelight Plus for some studies for a very long time, but the pupil size is a small challenge. And because of that, we are not able to at all times get that accurate measurements what we need. So that time we have to go back to WF or Contura. So I would say it's just one another technology in the market for now. But I
Mhm.
don't know if my thoughts are going to change.
Then would you still prefer lenticule or would you go for Innovize, ma'am? Which one would you say? So as a primary procedure then?
I would really, you know, not comment on it because having used three lenticule technologies, Contura, Wavelight Plus, showing all the options, I still feel it's supposed to be customized based on your patient.
Okay,
So that's why that entire algorithm. I know that was not a part of my talk, but that's why the entire algorithm. Based on the algorithm, you choose, and then you tell the patient these are the options available for you. Ask them their needs, the profile, and then choose whether flap or lenticule.
got it, ma'am.
I still will customize based on patient's need and their parameters and their features.
Got it. Zain, anything to add before we move on to the next talk?
No, just a corollary to what you said. So, how many ectasias did you have in the last few years? You said
Two
out
patients,
of
1,700.
okay. And what do you think? Suppose you are not doing you're not doing biomechanics, right? Pre-op.
Nope, nothing.
Okay, so if you would have done biomechanics and used every possible software, how many out of these would you think would you get rejects out of your 1,000?
True,
At
that's
least maybe at least
yeah.
50 out of 1,050.
Yep,
So
50.
now you have to choose whether you're willing to risk two patients of ectasia or you want to give 48 patients more of spectacle freedom without having any risk, you know?
Yeah,
So
So,
before you answer, Aditya, I think I will, as I said, the algorithm doesn't include not choosing a patient.
yeah.
It doesn't tell you to reject a patient. It just tells you whether to do a PRK or Smile Extra or Fakey IOL. So not now, but as we move forward, I think it will be a part of our practice.
right. So Dr.
I'm not, in
Pooja,
fact, my practice has increased. To be very honest, the cases where I would say probably fakey IOL, and I have a lot, we all have a patient. When you say fakey IOL, they get scared. They turn up after 6 months or 1 year. Some don't even turn up. I'm saying some, not all.
yeah.
Think and then come that I will come, I'll get it done now, who are desperate to get it done. So for those patients whom you are saying fakey IOL, probably you can switch them to a Smile Extra or something, is what I think biomechanics helps. So it's actually increasing my practice.
See, it
So,
gives you alternate.
Aditya, you know, my patients actually, if I end up telling them that there is something wrong and I'm going to switch to a PRK or something, I don't see them in the clinic the next day. You know? So,
Yeah.
they probably would have asked three, four more people and then eventually done a PRK somewhere else. So, that is a challenge I think we private practitioners face.
No, so that's true. But the other thing is, see, as you're doing more numbers, your practice increases. It becomes vitally important to make everyone happy. You have one or two patients who have ectasia and they have regression, blah blah. The kind of buzz that they create would actually impact your practice quite negatively. So I think as you keep improving, you need to have more and more benchmarks present to choose the appropriate procedure. And honestly, after doing Smile now for so many years, I feel that my cutoff for Smile is now coming down from -9 to about -7. So I'm moving more towards ICL as we do more numbers because I see sometimes there's epithelial remodeling. There is a mild cylinder coming back later. So then 2 or 3 years later, I feel, oh, this would have been better if I done ICL. And the other thing is, the patients ultimately they come for you. They don't come for your procedure. So they trust your word. So once you tell them that for you, the safest procedure that I will do is ICL, or the safest one that I will do for you is PRK. So it's time that we stop marketing the procedure per se and we market ourselves. I think that is the correct way to move forward. The
I think
patient
I
should
very well
trust you.
agree with you. Patients should
Yeah,
trust you and not the technology.
technology, correct. Yeah. So with that, I think we'll move on to the next talk. So it is now my pleasure to introduce Dr. Sushmita Sri Ganesh. Dr. Sushmita is a cornea phaco and refractive consultant currently at Netradama Super Specialty Eye Hospital in Bangalore. She recently got awarded the gold medal for her MS ophthalmology exams. She's done a fellowship in cornea and external disease at Disha Eye Hospital in Kolkata. She's done numerous publications presented at national and international levels and was also published in peer-reviewed journals. Most recently, she was also awarded the Best New Producer in IRSI 2021. And now we look forward to Dr. Sushmita speaking to us about presbyopic LASIK and the options available to patients above 40 who want to be free from glasses. Over to you, Dr. Sushmita.
Good evening, everyone. I'll start my slide share. Okay, is my slide visible?
Yes, you can proceed.
Okay. I'd first like to thank YOSI and Dr. Aditya Varman for giving me this opportunity. So my topic for today is presbyopic LASIK. Are we there yet? I have no financial disclosure. Okay. All right. So as we all know, presbyopia is the irreversible loss of accommodative ability of the eye that occurs due to aging, which makes it difficult to focus on near objects. There are various modalities for management of presbyopia. This can be broadly divided into conservative, such as spectacles, contact lenses, and pharmacological agents, and the surgical modalities. This is further divided into cornea-based, lens-based, and scleral procedures. Within cornea-based, we have additive procedures such as corneal inlays, subtractive procedures, which is the Excimer laser-based procedures, and molding procedures like conductive keratoplasty. So more in detail about the presbyopic procedures, as I mentioned, corneal inlays, we have synthetic inlays like Camera, FlexiView, and Raindrop. Nowadays, there are also biosynthetic inlays as well as tissue adhesion procedures. Coming to the LASIK procedures, which is the crux of the talk today, we have monovision LASIK or SMILE, multifocal LASIK called Presbymax, and laser blended vision Presbyon. There are also lens-based procedures such as refractive lens exchange with multifocal IOLs and presbyopic phakic IOLs. So presbyopic LASIK, there are two ways in which we can use Excimer lasers for presbyopic LASIK. One is to create a multifocal corneal profile, and another is to combine aspheric ablation profile along with monovision principle. When we look at the three main types of multifocal corneal Excimer laser profiles, we have multifocal transition profile, where there is a decentered hyperopic correction. This is mostly of historical significance and is not performed so much nowadays and is not preferred because it causes a lot of vertical coma. Then came peripheral presby LASIK, where peripheral cornea is corrected for near and the center is corrected for distance. Now, the drawback for this is in myopes, there's significant corneal tissue removed to create the hyper-negative ablation profile. So it was mostly preferred in hyperopes. But after this came central presby LASIK, where the central cornea is corrected for near vision and the peripheral zone for distance vision. This has become more popular. And in this central presby LASIK, it's basically pupil dependent, which is more physiological, as during the near reflex, there is meiosis of the pupil. So it makes more sense that the central cornea is ablated for near. Also, it requires adequate centration while performing the central presby LASIK. There are three types of machines that are available. We have the AMO Vizx, Supracore, and Presbymax by Schwinn. So a little bit more about these machines and procedures. The AMO Vizx was one of the first. It steepens the central zone for near vision and flattens the peripheral zone for distance vision. It can be performed in hyperopes up to +4 diopters and correct astigmatism up to -2 diopters. However, studies have shown a loss of 2 lines or more CDVA in around 10% of the patients. Also, the surgery itself increases the higher order aberrations. Next comes the supracord by Technolas. As you can see in this image, the central 3 mm zone has a +2 diopter ad, is ablated to create a +2 diopter ad, and a distance target of 0.5 diopter of myopia in both the eyes, or incorporating micromonovision, where a distance target of 0 diopter in the dominant eye is ablated. So the special thing about supracord is an aberration optimized presbyopic algorithm. Basically, this minimizes the aberrations that are normally induced during the treatment. There are various studies which show more or less a loss of more than 2-line CDVA ranging from 6 to 10%, ranging from 6 to 10% of the patients. Then there is the Presbymax by Schwinn. As you can see in this image, multifocal corneal surface ablation is created that is bispheric in nature. So central cornea is made hyperpositive with +0.75 to +2.5 diopters, and the surrounding cornea for distance with a gradual aspheric taper. The first module released was the Presbymax Symmetric, where both eyes achieve a 1.5 diopters depth of field. However, there were a lot of side effects like glares and halos because of this multifocal corneal profile that was created. So then came the Presbymax Micromonovision, where they incorporated an asymmetric correction with a 0.8 diopter difference between the eyes. This was slightly better accepted. And then the latest is the Presbymax Hybrid module, which induces differential depth of field in the dominant and non-dominant eyes. Basically, it creates a depth of field of 0.8 diopters in the dominant and 1.5 diopters in the non-dominant eye. This has the best stereo acuity and binocular vision. Some studies show that the Presbymax Symmetric had a loss of 1 line or more CDVA in around 33% patients, whereas the Presbymax Hybrid had a loss of 1 line or more CDVA in 6 to 8% of the patients. Then we have the second set of Excimer laser procedures, which is Presbyon laser blended vision. Here, okay, so basically monovision LASIK is where the dominant eye is corrected for distance and the non-dominant eye is corrected for near. And this has proven to be safe and effective. But with this, there were many drawbacks and very low satisfaction amongst patients because of loss of contrast sensitivity, loss of stereopsis, longer adaptation time. So Carl Zeiss Meditech came out with laser blended vision concept in their Presbyon machine. The principle behind this is, as you can see in this picture, an increased depth of field by inducing controlled spherical aberration, as well as micromonovision, where the dominant eye is targeted for emetropia and the non-dominant eye for myopia of approximately -1.5 diopter sphere. This helps create this blend zone for intermediate vision. So a non-linear aspheric ablation profile is used. It incorporates a precompensation factor, thereby modifying the spherical aberration. This creates a post-op spherical aberration which falls within the range that provides an increased depth of field without compromising the contrast sensitivity and quality of vision. This is a simulation for a -1.5 diopter defocus. This is how it would appear with adding spherical aberration, controlled spherical aberration. It becomes clearer. Also, with reduction of pupil size to 4 mm, it becomes even more clearer. When you combine these two, the clarity goes on improving. And along with central neural processing, this is how the simulation appears. Just to give a better idea of the difference between monovision and laser blended vision, this is monovision, where the dominant eye is corrected for distance and the non-dominant for near. And when it's combined together, the brain merges the two images to see near and far without glasses. However, there was a very low tolerance for this. Only 59 to 67% of the patients were able to tolerate it. This is laser blended vision. So you can see comparatively the dominant eye for distance and non-dominant for near, but there is also this intermediate zone. And the brain merges these two images to create a more tolerable outcome for patients, where 97% of the patients were able to tolerate this. When it comes to a presbyopic LASIK correction, patient selection is very important. As already discussed before, patients should be suitable for LASIK. A CDVA of no worse than 20 by 25 in either of the eyes, age 44 and above, patients who are presbyopic and dependent on reading glasses. The patient should be highly motivated. There should be no lens changes. Plus 1.5 diopter tolerance test pass. Quick suppression and fusion, tolerance of at least minus 0.75 diopters anisometropia with a healthy ocular surface. So in Presbyon, the range for correction is minus 8.5 diopters for equivalent myopia and plus 5.75 diopter hyperopia, as well as it can be performed in emetropes. We should avoid it in patients with very high expectations and low myopia less than minus 2 diopters. Preoperative counseling should be given priority. We should inform the patients not to compare both the eyes after surgery, explain about adaptation, which can take up to 3 months, chances of enhancement in the future. Patients with early cortical cataract need to be explained about need for cataract surgery in the future, also may not require multifocal IOLs. This is a step-by-step evaluation, a verification of the refraction and accommodation of amplitude to verify the functional age, which is input into the CRS master for Presbyon. Also, eye dominance test needs to be checked with finger pointing, hole in the card, and shooting like in these images. A plus 1.5 diopter tolerance test needs to be performed, and I'll show a short video regarding how to do this. We check for suppression and fusion, and the planning is done on the CRS master. So this is a very short video that shows the how to perform the tolerance test. So we give full distance correction for both the eyes as seen in this video. And we ask the patient to read the chart. Also, we give plus 1.5 diopter in the non-dominant eye. Then we ask the patient to read the chart up to 6/6 line. And then we ask them to go about doing their usual activities for half an hour, like looking at their phone, reading the paper, and moving about. Then we ask them to come back and we recheck the vision. We check both the distance to see if they're comfortable, if there's any blur or any intolerance. And we also check the near vision up to N6, ask them if they are comfortable, if they have any blur or any diplopia. So yeah, again, we ask them to look at the distant, at the chart, and we close the dominant eye, ask them to read the chart. So this gives them a good idea of how it might appear. We ask them if they're comfortable reading it or not. He's saying he's not, but once we remove the occlusion from the dominant eye, he's quite comfortable reading the chart. So there's no discomfort or intolerance, and we have to ask this a couple of times to make sure that they're actually comfortable with this. So this is when we would say that they have passed the tolerance test. Next, we would put all our data into the CRS software. As you can see here, there is all the refraction, the manifest refraction default target, and we can see the correction that we will get in the dominant eye. Also, the Z4 value needs to be input. We can take this from VASCA aberrometry. If we are taking it from any other aberrometer, we have to convert it into Malakara notation. We take an optical zone usually of 6.5 mm. Treatment method is laser blended vision and procedure is LASIK. K readings can be taken from the pentacam. Laser blended vision age and functional age can be input, dominant eye, and plus 1.5 diopter, pass or fail. Then safety panel, we put in the pachymetry that can also be taken from the pentacam. Ablation depth is input, and a residual stromal thickness, usually limit is 250, but we keep it around 300 microns. And we can input the mean flap, which is 100 to 110 micron, and flap diameter of around 9 mm. We do this for the other eye as well, and this gives us the ablation profile. This can be exported into the MEL 90 Excimer laser, and the LASIK procedure itself is like any other LASIK procedure as already shown before. So in our center, we did a study on 208 patients to see our initial results of Presbyon. We took both extremes, hyperopic as well as myopic. And these were our results at the ending of 3 months. Binocular uncorrected distance visual acuity was 6/6 or more in more than 92% of the patients, and the rest fell within 6/9. And binocular uncorrected near visual acuity at 3 months was N6 or more in 96% of the patients, and the rest was around N8. We also studied them at 1 year and saw the patient satisfaction, which was 97% in the myopia group and 96% in hyperopia group for distance vision, and near vision satisfaction, 95% in the myopia group and 89% in the hyperopia group. So patients were pretty satisfied. This was published also in JRS. So the outcomes of Presbyon is quite good. It's easily adjustable, meaning enhancements can be easily performed. No permanent visual effects are seen. So there's good contrast sensitivity, and night driving is also quite comfortable. Any side effects can be corrected by glasses. Good stereopsis, contrast sensitivity can maintain the blended vision even after cataract surgery, and it does not interfere with the cataract surgery itself. So I'd like to conclude by saying that presbyopic LASIK has many methods. We should assess the advantages, disadvantages based on the patient. And patient selection itself is very important for satisfaction. Patient counseling and management of expectations should definitely be given a priority. And as Pooja Kamar ma'am already mentioned, presbyopic correction with LASIK is not just an aesthetic procedure, but it also improves the quality of life of the person significantly. So are we there yet? I think we are. Thank you.
Right. Thank you so much, Dr. Sushmita. That was a fantastic overview of presbyopic correction. So I just like to add a few comments. So I've started doing Presbyon now for the last 1 year at a center. And I can say in no uncertain terms that the results are mind-blowing. But there are some difficulties there. The whole concept of Presbyon is extending your depth of field. So you don't just extend depth of field in your non-dominant eye alone. It works on the dominant eye also. So for that very reason, even if the dominant eye has a very minuscule refractive error, even if it is half a diopter, we treat the dominant eye also to induce the required amount of spherical aberration to extend depth of field. Whether it is positive or negative, the target spherical aberration is between 0.3 to 0.6. That's what gives you the depth of field without degrading quality of vision. So you need that 0.3 to 0.6 in the dominant eye and the 0.3 to 0.6 in the non-dominant eye. So what ends up happening is the dominant eye, even though it is supposed to look only for distance at plano, the dominant eye gets good intermediate vision also with plano refraction. So we see patients when their best corrected visual acuity is for distance is 6.5 and they have N12 for reading. Post Presbyon with spherical aberration, they get the 6.5 and the reading for the dominant eye goes up to N10 or N8. And in the non-dominant eye with the plus 1.5, which is you're targeting minus 1.5 refraction post-op. In the testing, you will see that yes, with the plus 1.5 in the non-dominant eye, the patient is able to read N5 or N6. But his distance vision in the non-dominant eye with that kind of refraction is only 618. But post-Presbyon with the spherical aberration and with the minus 1.5, the patient reads even 6.9 for distance while having the N5 or N6 for near. So that's when the blend happens. That's where the magic happens essentially. So there's a seamless fusion, and then the patient is binocularly good for both distance and for near. The caveats here are your refraction has to be ultra precise. This thing is extremely unforgiving for even minute errors. Even if you are half a diopter off in either eye, the blend is gone. It doesn't work. That's it. You can only afford to be a quarter of a diopter off. So in my initial days, the first 10 patients I had to end up enhancing 5 of them after 3 months. But then after I started to get my algorithms right, the workup right, the nomograms right, now everybody's on target. So if you're on target, it's absolutely fantastic. So now I would like to get Pooja ma'am's opinions on this. Ma'am, with the whole slew of presbyopic corrections available, what do you think is the reason that it's not caught up yet? It's not as popular as the procedures which are available for our under 40 patients.
Again, having access to Presbyon and Presbymax and Supracore, all three, I still would say that, it's not catching up the attention is because a lot of patients, not a lot, but some of the patients do regress for the reading with time. You can do enhancement, but it's still, not everybody knows how to enhance this patients. So for that fear, advising those patients a Presbyon or a Presby LASIK is becoming a small challenge. And the second thing is, our patients have a expectation that they want to be spectacle free for life. A lot of patients don't want to, give the time of neuroadaptation, of, let's say, to fuse the brain or for contrast sensitivity, multiple things. The patience in patients is not there at times. And that's why even if you advise it, um, of course, patients are not getting it done. So I think there's a small, and nobody wants to go back to glasses after they've done a Presbyon. So I think that's the challenge. It's not catching up. Because every time I counsel my patient and they say, oh, after a few years, if I have to do a touch up or go back to reading glasses, then what's the point? So the expectations of patients are different.
I have a very interesting thing happening here, ma'am. This is what I thought as well, that I'm going to have difficulty convincing patients because of the chance of enhancement, adaptation time, and all of that. The surprising thing is, these patients who are 40 plus, you tell them all of this. I feel that they're so desperate to get rid of glasses entirely that they're happy to do it despite these riders. So, how about
It's a big gray area, I would say, to be very honest. It's a very big gray area of why it's not catching popularity.
my theory is I think it is a difficult procedure to implement in a practice, not in terms of doing it, it's just LASIK, but in terms of doing an accurate refraction and the post-op. In the post-op, you have to be very careful and you have to see if the patient needs another half a diopter more to see a little better. And then they have to be enhanced for half a diopter. For example, the 5 patients I had to enhance were all for half a diopter of cylinder or half a diopter of sphere. So you have to be that accurate in your refraction. So I think as a procedure, it's a little tricky to implement. But how are the others, ma'am, like Supracore or Presbymax? Because I have no experience with them.
I think all are similar. As in, the technologies are different, but it's like your read-off lenses.
Right.
90% all lenses are there. It's the 10% which every lens is different. So it's the
Right.
same thing with Supracore, Presbyon, Presbymax, Read. So I think 90% all the technologies in terms of outcomes. I'm not telling you in front of principles. Principles are different, no doubt. But when it goes in the patient's eye, when you perform it on a patient's eye, 90% the outcomes are similar. It's just the 10% extra edge. And as you mentioned very clearly, it's a small laziness. So again, when it comes to presbyopia lasers, it's a small laziness, I would say, to um, choose or you know uh, knock down on just one of them. Everybody is confused. So like Sushmita very clearly gave example of what are the differences of each of it and how the outcomes differ. I have Presbymax patients who are equally good because Presbymax patients it's a small multifocal effect on the cornea with an EDOF. And I have Presbyon patients also who are happy, but you know, some Presbyon patients are not happy with the monovision which it induces. Some Presbymax patients are not happy with the multifocality. So I think the 10% is on the patient and not us.
I think that's where your adaptive optics has to come in and help us choose.
Exactly. So we've been, it induces. So there's a very nice paper on adaptive optics on presbyopic patients, where the spherical aberration change should not be more than plus 0.4 or 5. If your spherical aberration change in any of the presbyopic patients is going to be more than 0.5, those patients are not going to be happy because they lose that uh, they lose the depth of focus.
Correct.
So it is true, but of course, adaptive optics is little cumbersome. Not everybody can do it again. It's like it's like great grandfather of biomechanics. It's very difficult to incorporate in the practice. So we've a lot of times not done patients because we know that the spherical aberration induction is going to be more than 5. We don't touch those patients. We give an option of EDOF because they work very well, or we don't do anything at all.
Zain, I know you do monovision for your patients. Can you tell us about your experience and how happy they are?
Yeah, so see, the thing is that what I feel is that what Dr. Pooja said is absolutely right. Most of the procedures, are quite similar and they have their plus and minuses. But I think each and every procedure requires that small amount of monovision, whether it is Presby Max, Presbyon, whatever. And to do a good monovision tolerance test, as Dr. Sushmita showed, is extremely important. So, that there itself you can, and as she showed that you let the patient go out, have a walk with that monovision correction. So whatever procedure you're going to do, you are going to induce little spherical aberration to get better depth. But if they are happy with that initial monovision tolerance test, that really gives you a very good positive indication that this patient will be happy. And then higher the refractive error, the more spherical aberration is getting induced. So you are definitely adding on to whatever they are getting from monovision. So that is the key, I think, to do a good monovision tolerance test. It doesn't always have to be 1.5, it can be 0.75 also, and then you can tell the patient that you will be seeing this much post-op. Eventually, if you do the surgery well and you've done your refraction well, they do see better than what was initially promised.
Yeah.
The second thing I feel is that, refractive surgery, especially in metro cities, is very competitive practice. And most of these presbyopic patients have gone doctor shopping 3, 4 times. And most of them have been told that, you can't get it done. Now, if you do a good presbyopic LASIK, you can actually build your practice on presbyopic LASIK, because if they are happy, these patients will be really good. So I just 2 days back did a patient who, was sent by another doctor saying that if you do any kind of LASIK, you won't be able to see your toothbrush or toothpaste, and she was very scared. And I said, that won't be the case. You will be able to see. Do a good refraction, do a good monovision tolerance test, and she's happy. So you can actually build your practice on presbyopic LASIK also.
Do you do monovision only for hyperopes or for myopes as well?
Yeah, so I do it for hyperopes. I've started doing based on the principles of the READ software now. So READ software is on Alcon platform is doing it automatically. But if you know how it is done, doing the Q value modification, I've started doing it for hyperopes also. The myopic thing is only monovision, and it is very similar to Presbyon on Alcon platform. So if you have a high myopic correction, so the Q value modification is very small and it is similar to Presbyon. And for the hyperopes, it is similar to the READ software.
Right.
So I'm doing for both, yeah.
So,
But for any of these,
go ahead.
For any of these procedures, for example, if the patient is getting operated at 45, patient is a diabetic or something, how do we, what time do you offer them? Okay, you'll be glass free for so and so period. If at all, at the point of examination, there are no lens changes. How much time, if the patient asks, okay, how long am I going to be glass free? Or if the patient develops some cataract changes, how do we counsel the patient in the first place?
So for Presbyon in specific, what we do is if patient comes in the early 40s, we don't give the full minus 1.5 because they won't need the full minus 1.5 to see well and near because they do have residual accommodation. So for these patients, I'll target minus 1.25 or minus 1 also. So with the minus 1, they're quite happy. They read quite well at N5. And then before I do the procedure, I tell them that I'm giving you the near vision you need at this point of time. 3 to 5 years down the line, you will need touch-up. I don't say you might. I said you will. You will need touch-ups to see a little better at near. And they're happy to accept it because they've been, like Zain said, they've been told everywhere that you can only get glass-free vision for distance, and near you'll have to wear glass. When you tell them this option is there, they're ready to accept. So that's one thing. The other thing is, you asked me about the lens clarity. So I use eye trace. So the eye trace says the dysfunctional lens index is more than 7. I just go ahead.
Okay.
And of course, you don't need it. You can just do a slit lamp exam, look properly for lens nucleus
Correct.
sclerosis. That's enough, of course. If a Presbyon in specific, the theory goes, I've not done this yet. Theory goes that once you do Presbyon, the patient develops cataract 10 years later or whatever. You target plano and non-dominant and the same refraction of minus 1.5 in the non-dominant eye. Okay, because the spherical aberration that you've induced on the cornea is still there. The target is 0.3 to 0.5, right? At that point of time, you have to check on your aberrometer what the spherical aberration on cornea is. If it is still between 0.3 to 0.5, you choose a lens which is having neutral sphericity, that is zero spherical aberration, like the Bosch law Investa or something. So you put that in. If you've done hyperopic laser and you've induced negative aberration, and if the negative aberration is lesser than what you need when the patient has got cataract, put in a negative spherical aberration IOL.
Okay.
You put an eye Hans or something. So we get them on target. So they still have the advantage of Presbyopic even after having cataract, without having to undergo a multifocal IOL with the glare halos and contrast loss that comes with those lenses. That's the theory for Presbyopic. For Presbymax and the other ones, I'm not too sure. But again, the Presbyopic thing post cataract, it sounds too good to be true. I'll have to do a few myself to decide if it actually works so well. But the few people I've spoken to have done this are giving me very positive feedback.
All right.
Also, sir, what is your choice of procedure for a patient who is 38 or 39 years old?
38, 39, I'll still ask them to undergo smile only. But I tell them that you will need glasses at 42, whenever. Sometimes I do undercorrection. I undercorrect by half a diopter, so they get little better reading until they're 42 or 43. You can do Presbyopic post smile also. So by nature, all of my smile caps are at a deeper level. They are at 140. So if they come later to me for Presbyopic, I do a 90 micron flap over it and just proceed as usual.
So, Lipi, just for that 38, 39-year-old, just one tip is that, just check the near vision of the patient with the glasses pre-operatively and see how comfortable they are for the near vision with and without glasses. So if they are better without glasses, okay, you know that their accommodation is weak, they are going to require glasses more. If suppose they are seeing equally well with the glasses and without the glasses, then you can do your originally planned procedure. If I feel that they are slightly, not so good with the glasses, then I'll do some amount of monovision correction just to make sure that the reading glasses would come a bit later.
Okay.
Okay, so I
Thank
think
you.
we'll move on to a last talk now because we're just starting to overshoot our time. So, our last speaker of the day. So it's my pleasure now to introduce Dr. Arnav Singh Saroya. So Dr. Arnav has his MS ophthalmology, his FAICO and FWCRS fellowship. He's been awarded the APACRS travel grant for his work in the intracorneal ring segments. He's won multiple scholarships at both national and international meetings. He's won film festival awards. He's done work on Smile Extra and won an award for it as well in the APACRS. He's got multiple peer-reviewed articles and publications, 4 chapters on PDEC, and also published on glued IOLs in international books. He's been awarded many medals for his academic achievements, and now he is going to speak to us on a difficult topic: navigating complications in refractive surgery and still providing the patient an optimal outcome. Over to you, Arnav. Take it away.
Sure. After an extensive discussion on the topic of PRK and LASIK, Presbyopic and everything, and tried to summarize my topic as quick as possible. Starting from, the refractive surgery procedures have been broadly classified into keratorefractive and lenticular based. What we're going to cover today are the pertaining to PRK and LASIK. So, in what is done is Excimer laser ablates the anterior corneal stroma and creates a new radius of curvature. Depending on the lineage of surgeries, PRK, LASIK, LAC, EK, epiLASIK, mechanical PRK, or transepithelial PRK. How they work is they work by reduction of induced aberrations, and based on that, Excimer laser profile has been classified into topography guided, wavefront optimized, aspheric, or Q factor adjusted profiles. So starting from the surface ablation complications, they can be intraop or post-op. Most commonly, intraop is decentered ablation or irregular ablation because of debris on the corneal surface. Short-term complications post-op being pain, delayed wound healing, sterile infiltrates or haze, which we used to come across pretty often. Long-term being under or over correction, regression, decentration, haze, rarely ectasia, very commonly dry eye. Decentration, how it happens is if the laser beam is not precisely aligned, if there is poor fixation throughout the surgery, Higher power people are more prone because of longer operating time and leads to an increase in the corneal astigmatism. Under or over correction due to abnormal healing process or biomechanical changes of the cornea, best is practically to treat under correction and advise the patient to wait for 3 or 6 months, recheck the refraction, and then plan. Regression refers to minimal or no refractive error in the immediate post-op period. Refractive regression is due actually in most common cases due to epithelial hypertrophy, stromal remodeling, axial or lenticular causes. Regression, if noted, is mostly common in the first 3 months. Greater and smaller myopic corrections are associated with much higher regression rates and also higher rates of haze development. Very commonly, we have been using mitomycin C with an adequate optical zone and stable fixation. Then coming to the one of the most common complications like corneal haze, which presents as a superficial opacification of the normally clear cornea, leading to a transient decrease in the corneal transparency. It is actually a part of the postoperative healing process, but obviously the patients won't understand. It's usually graded according to the Fantas et al. Grading system. Prophylaxis and treatment includes usage of topical anti-inflammatory drugs like 0.1% dexamethasone, fluorometholone or prednisolone acetate 1%. These are used to inhibit both late and early manifestations of the inflammatory process. Also, like ma'am told, ice packs 10 minutes pre and post PRK together with chilled BSS solution. Also, use of chilled BCLs helps to decrease corneal haze and pain pre, intra, and post op surgery. Delayed epithelial healing. It causes persistent blurred vision with epithelial defect with well-defined borders. Stroma shows folds which are secondary actually to edema. If you feel that the defect is not healing, replace the BCL, discontinue the steroids, and ask the patient to use lubricants as far as possible, along with an antibiotic drop. Once the epithelium is healed, we can restart all the drops as per the protocol. Other rare complications include ocular hypertension because of low potent steroids, postoperative pain, which can be easily managed by NSAIDs, BCL, systemic analgesics, and also lubricants which are preservative free. I have seen very few cases of sterile infiltrates as well, which are single or multiple without discharge. And white infiltrate is small, less than 2 mm in size. And if you feel that there are multiple infiltrates or there are more than 2 mm, then we should start fortified drops as early as possible. Refractive errors that can according to the FDA protocol has been discussed by various speakers. However, we used to follow a protocol of treating myopia up to 8 diopter astigmatism, myopia up to 8 diopters, astigmatism up to 4 diopters, and in very rare cases of hyperopia up to 5 diopters. The best results with the lowest incidence of complications occur in lower ranges of myopia, astigmatism, and hyperopia. Also, we should consider before deciding which candidate, as discussed with Dr. Sandeep, which is a good candidate and which is a poor candidate. The wound response following LASIK is quite different to that of PRK, LASEK, or LASIK. LASIK preserves the corneal epithelium and the Bowman's membrane, and this causes the effect of wound healing and problems associated with surface ablation. Epithelial damage of the corneal flap due to severe hydration or mechanical injury during LASIK procedures can evoke excessive wound healing. This is an extensive list of all the complications of LASIK that can occur intraoperative or postoperatively, which can be divided into flap-related, FSL-related, or others. Postoperatively, early onset can be again flap-related, interface, or others like dry eye, high order abrasions, reduced contrast, or late onset. I just hope my patients don't end up seeing this slide. LASIK complications can be intra-op, early post-op, or post-op. Most commonly, what we've seen classically and has been discussed in textbooks and various meetings and everything, microkeratome related are flap buttonhole, free cap, incomplete or short irregular flaps, or corneal perforations rarely. Epithelial defects, wound dehiscence, limbal bleeding, flap wrinkling, etc. Early post-op, including over or under correction, dislodged flaps, flap wrinkles, epithelial abrasions, DLK, or strands of Sahara. Infectious keratitis, epithelial ingrowth, which we do see very commonly, and it is a sign that the patient has been treated with microkeratome or a femtosecond LASIK. Late post-op, including regression, induced regular or irregular astigmatism, endothelial cell loss, ectasia, glare and night vision problems, which is very common again, loss of or diminished contrast sensitivity. Suction loss, which is very common in deep set eyes, flat corneas, or the patient has a sudden eye movement during surgeries. In microkeratome LASIK, machine identifies suction loss and the flap movement is stopped. In femtosecond LASIK, a peripheral asymmetric tear meniscus is one of the first signs that should be identified as early as possible. If it occurs before the side cut, we can make a new one with the same parameters. And if it occurs during side cut, then a new optical zone should be made 0.5 mm smaller. Incomplete or partial flap, lamellar dissection is described to complete the flap in case the hinge lies in the optical zone. And optical zone can also be reduced to prevent the flap. However, the pupil size should be taken into consideration. Then there is a sort of other complications like shredded flap, buttonhole flap, which is very commonly seen in steeper corneas, appeared and in steeper corneas and rare, but buttonholes can occur with femtosecond lasers as well. Steep corneas of more than 48 diopters, localized thinning or scarring, partial full thickness buttonholes can occur during the femtosecond laser pass or if the gas passes through a focal area. Then you have free cap. The free cap must be gently removed from the microkeratome unit and placed epithelial side down on a thin layer of saline. And if the cap does not fit perfectly, it may be even put upside down. Then you have very commonly interface debris. As discussed in the previous talks, we should make sure that pre-op, the entire examination, including makeup, mammalian gland secretions, epithelium, or pore cleaning of the microkeratome should be taken care of. Management of any of these inciting factors and making sure that you do copious irrigation post-surgery to make sure there is no interface debris. Epithelial defect or loosening is very common in epithelial basement membrane dystrophy or patients with recurrent erosion history, older patients, poor quality blades with large flap diameters or pivoting microkeratome. How do you make sure, how do you manage is realign all the loose epithelium and replace all the epithelial tags in their original position. Also, check the stromal bed carefully for any leftover epithelial fragments and it prevents the chance of having epithelial ingrowth later. Use of preservative-free lubricants. If there is any large area of severe epithelium loosening or sloughing, consider debriding the epithelium and postponing the surgery on the follow-up. Now coming to the post-op complications, flap displacement, very rare, but yes, it is documented. The most common symptoms of a dislodged flap are acute pain, decreased vision, or it can range from a small area of folding at the flap edge to a completely dislodged flap only adherent at the hinge. In general, a femtosecond laser flap becomes more resistant than a microkeratome flap to displacement because the scarring that occurs with the form. And also, patients should be told to avoid rubbing or getting hit, and they should be very careful during any of the sports activities. If the patient is into professional sports or any other activities, they should be guided about other modes of treatment. Infection, sort of infections can occur. It will be another topic as well. Diffuse lamellar keratitis, one of the most common complications, also called as Sands of Sahara syndrome. It is a non-specific sterile inflammatory response to the corneal insult. The onset typically is within a few days of the surgery, and as DLK progresses, the interface can coalesce into clumps of inflammatory material. Then one of the other common complications, which is pressure-induced stromal keratitis or PISC. After LASIK, elevated IOP can cause a sterile PISC that can mimic like DLK. However, typical history is very important. Uh, how it occurs is because of elevated IOP, and the patient often turns up to be a steroid responder. Recheck the IOP. We can start the patient on, we should taper and stop the steroids quickly, put a patient on AGM as early as possible, and keep a frequent follow-up. Central toxic keratopathy, originally it was thought to be a severely form of DLK, but now it's considered as separate entity in itself. And signs include mild to severe corneal opacification, corneal thinning, and also flattening. Management steroids are not thought to be very helpful because it is not inflammatory. However, it causes hyperopia and central opacity, which itself tends to correct over a period of 6 to 18 months. Microstry, this occurs mostly because of after the treatment of high refractive errors. Microstry can also occur as a result of excessive flap hydration, which can alter flap bed alignment, as we've discussed before. Causes include mild flap bed mismatch once the flap is replaced after the laser ablation, or excessive flap hydration. Prevention includes avoid excessive hydration during the procedure. Macrostry, in contrast to micro, the flap folds are very significant and decrease the visual acuity. Prevention during surgery, making sure that the flap is well opposed and the marks are properly aligned, as discussed by Dr. Lippi. And while lifting the speculum, you should make sure that you prevent bumping the cornea and displacing the flap. Dry eye syndrome, one of the most common post-op complaints given by the patient, and the management still remains the same, using preservative-free tears during the post-operative month, using artificial tear gels and ointments, using cyclosporin drops, punctal plugs, which is in very severe cases, and epithelial growth, which is again one of the a commonly seen complication after surgery. It is commonly noted at the flap edge, advancing inward less than 0.5 mm. When it extends about 1 to 2 mm from the flap edge, it can cause problems, or when it is in the visual axis. Management includes when it is causing significant issues with the visual acuity, and serious consideration should be given if if the epithelial growth is more than 2 mm from the flap edge. Glare and halos, corneal ectasia, central
Arnav, I think your audio is breaking up. Can you just try rejoining?
I'm not able to hear him at all.
Yeah, I'm just calling him up. Give me a second. Yeah, Arnav, we can see your video, but your audio is off, so we're not able to hear you. Uh, yeah, so he's rejoining. No issues. He'll start now.
Okay, I had no clue, sir. When did it happen? I'll just run through the last few slides.
Yeah, you are on Central Islands.
Yeah.
Sure, sir. All right, sir. Um, So central islands are small localized area of steep corneal curvatures within the central cornea, and it causes decreased, uncorrected, and best corrected visual acuity. Topography, when we see it on topography, demonstrates an area of central steepness on the order of about 1.5 to 3 diopters. Uh, it uses it and the causes include beam profile abnormalities or irregular central laser pulses. More common is it's more common in PRK compared to LASIK, and management includes most central islands resolved without any additional lasers over a period of about 3 to 12 months. After LASIK, the central islands tend not to resolve very spontaneously, and they do require enhancement procedure. Uh, that's it, sir. That was the last slide. I tried to make it as short as possible, but I was constantly fearing I'm missing out on something or the other. So I ended up making an extensive slides.
No, thanks, Arnav. That was actually very good. So, it is important to actually know all the complications associated with refractive surgery. A problem
Endless.
is that we encounter them very infrequently. So,
Yes, sir.
when actually we are faced with a situation, we're not quite sure what it is and what to do. But
Correct.
it's important to know, it's important to see pictures time to time. It's important to discuss these cases, with colleagues and seniors, take opinions and understand. So, because that is how we learn. Refractive
Correct, sir.
surgery is very different from others. But what we must remember is that ultimately we are dealing with very young patients. We are dealing with patients, who have their whole life ahead of them. And as refractive surgeons, it is our responsibility to at least make sure that after the surgery, we should at least keep their best corrected vision, not more than one line worse than what they were before surgery. That much safety we should have as responsible refractive surgeons. So, discussion is open. Aditya, Pooja, you can just give your input.
Yeah, so that was very extensive, Dr. Arnav. That was very good. So there's nothing much to cover beyond what you've said. You covered everything. There's one thing I wanted to discuss with the panel and Dr. Pooja, ma'am, in particular. One of the reasons why nowadays I'm not preferring smile for more than -7 or -8 spherical equivalent, no? Sometimes I see a couple of months later, they come back with epithelial remodeling. The epithelium grows back to about 60, 70 microns, and they have a diopter or diopter and a half of regression. Happening more with smile than LASIK. Any inputs on that, ma'am, and how to tackle this issue?
Mm, I know I again am sounding little over precautious, but do you use cyclosporin for your patients?
No, I do not.
Again, it's an overkill for many, but trust me, what you said, epithelial remodeling and a pseudo regression. It's a pseudo regression, it's not a true regression.
Correct.
And even if, let's say, you say that epithelial remodeling will happen, I'll do probably a PTK or something, it's not always the right feeling. So, over the past 10 years of being in refractive surgery and seeing the experience of Dr. Rohit and others in the hospital, using cyclosporin for at least 3 months if you can do 6 months, but that's not needed. 3 months gives such good epithelial remodeling. It doesn't give a erratic epithelial remodeling. It gives a very fine epithelial remodeling which is needed, and that reduces the chances of uh, this pseudo regression or induction of myopic error because of the epithelial remodeling. You may not need it for all the patients, but like Zan mentioned, there is a plethora of complications you see very occasionally, but you don't know which one patient is that occasional patient. If a patient can afford more than 100,000 rupees of a surgery, which is like Smile, I'm sure they can afford 3 months of cyclosporin. So giving that reduces the epithelial remodeling quite significantly, because epithelial remodels erratic when there is a ocular surface issue, and you have a lot of computer users. Whenever you have a lot of computer users, they don't blink well at times, and that can lead to tear film changes, which leads to ocular surface issues, and that's when leads to epithelial remodeling being erratic, especially for high diopters. They already have a flat cornea, which is going to make the epithelial compensate, and then they have an ocular surface change. So I think using it for 3 months is no harm, not just for Smile but for PRK patients also.
Right, ma'am. Right.
And one
Also,
thing I want to say, that including myself, if you think you cannot handle a complication, there is no harm in referring it to a colleague or a senior who knows how to deal with it. Because, as again Zain mentioned, these are the patients who can most probably afford one line loss of vision, not more. And when you're trying to work around complications, you can have, you know, you don't know the outcomes. So don't be shy to refer it to a colleague or a senior whom you know can take care of it, and you yourself can be present there for managing the case, so you'll learn. So I think that's the key in refractive surgery complications.
Absolutely, ma'am. Absolutely. Well said. Any more comments from the panel? Zain, anybody else who wants to make any further comments?
so I think lenticules probably have a smaller optic zone than LASIK. So probably that is why, in the higher refractive errors, you may get little more epithelial remodeling as compared to what a LASIK would give. So that could be one of the reasons why you are getting that
Correct,
epithelial
correct.
heaping up.
And that's why for these higher powers, I started to enhance the zone by another half a millimeter. But then if I do that, then the amount of tissue I'm taking is more. So that's why I started doing ICL instead now,
Mm.
to put it another way. Yeah. Okay. So I guess we've come to the end of the webinar, and we've overshot by half an hour. So I think we're improving on our time, Zain. Last time we
Better,
overshot
1 hour 45 minutes.
45 minutes. This time it's only half an hour. Next time we'll aim for 15 minutes. So we're progressing slowly. So I think it's a time for the vote of thanks. So I'd like to thank all of the speakers. Dr. Pooja, ma'am, thank you so much for spending your Sunday evening here with us. Despite being sick, you stayed here for the whole 90 minutes. It's very kind of you, and your input and your talk was absolutely amazing. Thank you so much for joining us. Thanks, Dr. Lippi, for speaking here and also for helping me put this session together. Thanks, Zain, for moderating as usual. Very nice inputs. Thank you, Dr. Arnav, for your very extensive talk on complications. Thanks to Dr. Sushmita on her talk on presbyopic LASIK. Very nice and a superb talk. Dr. Sandeep, thank you again for your talk on PRK and how Excimer's work and its practical applications. Very nice talk as well. I also like to extend my thanks to Numorotech. As usual, Sai and his team have done a great job in putting this webinar together. It always runs flawlessly and putting out very nicely designed flyers so they can distribute among everybody. What happens with these webinars is that we get views retroactively. So at the time of the webinar, there's very less viewers viewing, but just like how we had an episode 1, there's only about maybe 10 or 20 viewers at the time. But 2 weeks after the webinar, the views on YouTube are close to 500. So there is a lot of interest in what we're doing here. So the idea is to keep this as a resource material for young ophthalmologists to come back and refer to. whenever they need to clarify any doubts they might have in refractive surgery. Very excited to take this forward. Next episode we'll be doing another couple of months from now, hopefully in February or March, where we'll be discussing lenticule extraction. That one's going to be very exciting. So I look forward to seeing you all there. Any last words, ma'am, Dr. Pooja? Okay, so I think we'll close webinar. Thanks to everyone again. Looking forward to seeing you all in episode 3. Thank you.